Good morning, everyone. It's that time, and I'd like to begin the meeting, please. Welcome to this public board meeting of the ICB. It is a meeting in public, I should say, not a public board meeting. And following feedback, actually, from the public, to better enable those who are tuning in and those who need to follow, we've included larger name badges at the meeting, or we will be actually in future. So we've got to make them slightly bigger. Part of our commitment to our wide geography involves rotating around meeting rooms in the patch, and this can cause a little bit of difficulty sometimes. So in this instance, the camera available in this chamber in Reading is a fixed focal length camera. Very technical. Which means we cannot zoom in on individual speakers, so apologies for that. But to ensure people at home can follow, we'll be asking all speakers to kindly raise their hand, briefly stating their name and role before each contribution. I know it's a pain, but it's very useful for those that are dialing in. A few welcomes and thank yous and goodbyes, if you don't mind. So, as you know, I'm covering as acting chair whilst Javed is on extended leave. I'd like to welcome Matthew Metcalf. This is his first meeting in public, and he started on the 1st of April. We've been keeping him busy, but this is his first appearance here. And this is the first time for Karen Beach, who's our interim Chief People Officer. So welcome both to this meeting. And unfortunately, this is the last meeting for Steve McManus, our CEO, and Nick Broughton sat over there. So I have one out and one in. We'll be starting on the 3rd of July, so I'm delighted to say. And Nick is currently the member for mental health, so we'll be seeking to cover his board position when he leaves. Very important for me to formally thank Steve McManus for his excellent leadership during this time and his wisdom and strident approach, let's say. Also would like to thank Neil MacDonald for covering as NHS Foundation Trust partner member whilst Steve was our CEO, and subject to further discussion, Steve will return to the NHS Trust partner member role. We'll just make sure that is fully discussed. Also today, I need to announce that Shaheen Jinnah has unfortunately had to resign from her primary care member partner position with effect from the end of June. So this is her last meeting in public. So just again to thank Shaheen for her contribution. Thank you very much. We will miss you, but we will commence the process to appoint a new recruit and a new replacement. All right, so apologies for absence. Apologies from Neil MacDonald today, and we can move on to the main body of the agenda. So first of all, minutes from the meeting held actually on the 21st of March. Are there any matters arising and any comments to make before we sign off those minutes for approval? Matthew.
Thank you, Chair. So I just wanted to pick up what's recorded as an action under the place-based partnership paper. So that we had a wide range of discussion about the principles supporting place-based partnerships. I think the action actually is captured really in the minutes, and that's that when we're looking at place-based partnerships, it's really important to align our financial strategy and our resource allocation to support place-based partnerships, and also that the principle of subsidiarity is aligned to our work on place-based partnerships and baked into our principles. So we didn't discuss that with Catherine. We didn't record that as a particular action because we felt the notes taken at the board meeting were clear enough for that regard. So just to try and make that clear, Sim, if that's okay.
Thank you, Matthew. Yeah, we understand that. So I apart from that, then all matters arising, all the actions are now closed and reflected in the action log, which is item 3.1. So may I take the minutes then as approved? Thank you. Minutes approved, Catherine, so we can take those on. Right, declarations of interest. The current register is attached for information, and please come to Catherine if there are any changes in your declaration so that we can keep this as a live document which is fully up to date. The nature of our board with partner members means that there are inherent interests because of the organisations that the partners are leads for. So if we look at the items where there are interests today, item 8, the performance report, 9, finance report, 11, operational planning, 12, joint forward plan, 13, digital and data strategy. But items 8 and 9 are not for decision. So we need the perspective of all our members. So we've agreed that they participate in the discussion. If you look at items 11, 12 and 13, they are for approval, but all members can participate in the decision on this occasion, just to be absolutely clear. So questions from the public. We have had 3, I believe, and what we're going to do today is get the relevant executive to answer that question in their portion of the agenda today. Oh yes, that's right, and we'll publish all answers to all questions. Is that right, Catherine? Within 20 working days of this meeting. Excellent, thank you. Now moving on to the next section of this meeting, we ask all of the non-exec directors actually to talk about, to give a little feeling about their motivation to becoming a non-exec director and their understanding of values and the way they present themselves to the world. So today we're going to ask Saqib Ali to share with us his reflections and views on his own personal agenda. Saqib.
Family and can you hear me now? Is that better? Okay, brilliant. So it'll sound as if it's this is my life, because I'm going to go through my different family members as well as my journey. But my journey actually begins in 1987, I think it was. Edwina Curry and the egg scandal, and that was when I was going to med schools around the UK. So some people may not be aware, but I actually started my career as a medical student. And so I actually got an offer from University of Leeds, went up and did my first year of med school. I always joke that I was the first into med school and the first out of med school, in that I actually switched careers, or I switched to a science degree with the intention of going back to medicine when I finished that degree. I actually got an offer to become a trainee accountant with Deloitte Touche Ross, as they were, an unconditional offer. So I actually switched to that and never returned to a white coat again, but more about the white coat. I then had the occasion to actually spend 8 weeks of my life in a hospital in 1996. So I had delayed an appendix that was about to burst, possibly had done. I then spent the next 8 weeks in Bedford Hospital. I lost 1.5 stone in weight, had 2 surgeries. My appendix was removed, 3 foot my intestine, which I should have done a warning at the beginning if anyone was squeamish, but we wouldn't be in this room if we were squeamish potentially. And came out of Bedford Hospital, and that was the first time. Another warning: if people aren't aware of what the silver box is that leaves the ward, that's when I first saw a silver box leave the ward, and that was really shocking as a 25-year-old. My ex-wife was a district nurse, and missing Christmases, coming sometimes for the Christmas dinner and then going back out when she was on duty. I think that really showed what it means to be in the NHS when you're really living and breathing NHS day in, day out. My mother was an admin in the NHS from the late 80s in something that was called North West Thames Health Authority. And I guess with what the Hewitt Review is potentially referring to of organisations coming closely together again, whether we head back to health authorities or something similar, it'll be interesting to see. My father was an imam in Bedford Hospital and Bedford Prison, and for his later years, even though he was an accountant, he spent many years meeting patients, talking to interfaith groups, and dealing with the inmates at Bedford Prison. I was about to say Bedford Hospital, but you can leave the hospital. So he dedicated his life to that. And the health angle was he actually had glaucoma in 1984 when he was working in this part of the world for what was Burma Castrol at the time, that was later to become part of BP. So just down the road at their site, their offices in Pangbourne. So over the next 20 years, he lost most of his eyesight, and we regularly went to Moorfield. Moorfield Hospital now has a base in Bedford, but we used to have to go down to London, and he had 2 surgeries that were possibly done too late. So over the rest of the time after retinal damage to his eye, he steadily lost his eyesight entirely. So I mentioned that I was the first medic in our family. You know, I had uncles and aunts that were doctors, and that perhaps was part of the driver. My parents weren't really in the medical field, but my brother then became a doctor, and he's an honorary consultant at Radcliffe. And Catherine, yeah, I do need to declare that he's on various different national programs as well. So I will be putting that on the schedule. They point out he's honorary, not paid. And then in 2017. This brings me back. So whilst I had to have repeat surgery in 2008 and another foot removed, apparently there's a 12-year, 50% chance that you have to have surgery again. So 2020 passed without me needing surgery again. So I'm grateful of that. But in 2017, I did a Facebook post and I wrote, "I'm screaming so loud, but the world cannot hear me." And I'm going to tell something that some people are aware of that were on my board interview when I joined in, I'm trying to think when the interviews were. Possibly was it February of last year or something, around that sort of time. And this is really much a taboo amongst men and a taboo amongst the BAME community. So my wife asked me to go see A&E. I went to see A&E, met the mental health nurses that day, was told to come back the next day, and somebody over the next 2 weeks saw me. At that time, I was audaciously having, I guess, done 4 years with Lloyds Banking Group, trying to raise £1 billion to rescue Co-op Bank. And I think I've always been somebody that's had ambitions and trying to do things that perhaps might seem totally impossible, but I always set myself high goals and high standards. And over the next 2 weeks, I was diagnosed with bipolar. And for me, it really brought home how the NHS is there to serve us in any time of our need, you know, whether it's when my kids were born, I've told you about my family and their involvement with the NHS, or for me. And at that point, the thing that I was most worried about having this diagnosis, this thing that, you know, seemed super scary, was if I went on medication, which I've now been on for 6 years, would I still be me? Would the medication change me? Would I then be somebody different? And that was my greatest concern. And I was in tears as I was telling the nurse, the male nurse, that was what I was concerned about, that I didn't want the medication to change me. And over the 6 years, I guess I can tell that whilst the highs and lows are perhaps more manageable or more managed on a narrower band, I'm still me, and I now regard that as my superpower. So to conclude, what I'd say is everyone in this room, why we're here, why we live in the NHS, why we're putting the residents and the public and the patients first. We live and breathe the NHS. We are the NHS. Thank you.
Sahib, thank you so much for sharing that. That was quite overwhelming, and it really gives a sense of why we're all here. Thank you.
You're welcome.
Right, moving on. We're going to ask Steve McManus, please, to present the Chief Executive and Director's report. We'll be discussing that afterwards.
Thank you, Chair, and for members of the public, Steve McManus, the ICB Chief Exec. So I'm just going to pull out a few particular areas from the report, recognising that colleagues will be covering in more depth some of the other topics throughout the agenda. Just before kind of going into the main body of the report, just a quick kind of reflection, I suppose, around some of the items that are coming to fruition today in this public board, and those items being a measure of the increasing maturity of the way that this system and this ICB is operating within that system. So over the last 6 months through the ICP board, we've now got a published ICP strategy, across our NHS and local authority partners, with involvement from voluntary sector and other organisations within this system. That sets out some of those longer term ambitions over the next 5 years, for our resident citizens, our population. Today, we'll be talking through the joint forward plan that Rob Bowen and colleagues have been working hard on, which is the sort of NHS's response to that ICP strategy and those ambitions. And that will come back again in public for final sign off, I think, Rob, in July. We've got today, through the work that Ross and colleagues have been doing again across the system, the digital and data strategy. And we'll be seeing coming through in the summer in July, the people strategy, both really important enablers for how we start to realise over the next period those ambitions that have been set out in the ICB strategy. We're doing that in the context of an ICB board that itself, is maturing with board subcommittees that are doing the work of both overseeing strategy, overseeing assurance, and supporting the culture that develops within our ICB as an organisation, but also how we work together across the system as well. I think we'll see again through some of the work that Rob's doing a further development of our kind of underpinning system approach and some of the other critical areas that we need to develop together that enable some of those ambitions that are set out in the ICB strategy coming through over the coming months as well. So I think it's really important, Chair, just to kind of land that progress that we've made and the fact that we're at a point where we've really started to lay the tracks down into the future around how this particular system, with the role that the ICB plays within the system, is working for our kind of citizens and residents. So just going into the report, just initial overview. So part of the past 2 months has certainly been marked by the continuing response again across the system and as an ICB team to industrial action. I really want to pay tribute to colleagues across the system and here within the ICB, given the continued level of service demand and the critical events that we've also had to deal with during that kind of period. And I know, Matthew, you'll be picking up through kind of your report, some further detail about some aspects of the performance that we've seen over this last period. Just a quick touch on partnerships. So again, really important in terms of our relationship across this system is working with the vibrant voluntary care sector. We have an enormous range of voluntary care organisations, a huge amount of people across our system who are giving their time through voluntary service. I'm really pleased that we've been able to fund the VCSE Alliance going into this year, which continues to support the work of the VCSE and also the work at place level of Health Watch. Again, really pleased that we're developing a partnership agreement with the VCSE in terms of how we're going to work together. It's again that laying the tracks down over this next period about our work with the voluntary sector and how we can really enable the voluntary sector to continue to add value into the work that we do across the whole of the system. And again, an example of that is the work that the voluntary sector has been directly engaged with through our place teams around the 2-year funding that we've been able to support around health inequalities across our geography. Just want to come to, again, an example of, I think, the kind of growing maturity of the work we do as an ICB. One of the key things we are able to do is our convening role. So over the last period, we have seen a whole system event around the joint forward plan at the latter part of March, bringing again colleagues from right away across the system to engage in that particular agenda. So what we're seeing today when we talk about the joint forward plan has been developed and has had really excellent input from colleagues across the system as we continue to develop the detail there. Again, at the end of March, we convened colleagues from across the system around urgent and emergency care work, including our work around virtual wards. We've been working with clinical and care professional leadership groups, and again we had a session at the end of April that brought colleagues again from across the system around that. And in June, with the support of the Vice Chancellor of Oxford Brookes University, we've got our higher education, further education establishments, again with colleagues from local government, from the NHS, and further afield, coming together around how the education sector within this system can support our workforce development over the coming period as part of our people plan. So some really good examples of how we are leveraging our convening capability as a leadership team. Just want to touch briefly on some of the strategic landscape over the last period. So we've seen that the CQC have signalled the work that they will be increasingly doing, looking at CQC assessment, the Care Quality Commission assessment of ICSs. So again, noting that the quality regulation by the CQC will take place at some point at a whole system level. It's an area of focus for us as a board with system partners and across health and local government colleagues, given how absolutely interconnected we are with local government and NHS partners in terms of the services that we're providing that will be subject to CQC oversight. And we'll be kind of reporting back on some of the outputs and early learning from the pilot areas in terms of the CQC work with other systems as we start to think about kind of our preparation and response to that when it comes to us. Just want to touch again an important report through Patricia Hewitt. So the Hewitt review was published on the 4th of April. 6 key recommendations that I've just noted in my report, really aiming to increase the value that ICBs and integrated priorities within systems can add to the health and care of our populations. It directly connects with other publications such as the Fuller Review regarding the development of neighbourhood teams and importantly in terms of the work that again is happening across NHS England regarding the operating framework and the relationship between the kind of national bodies, regional bodies, systems such as ours and individual partner organisations. So again, we kind of wait a formal response from government in terms of the Hewitt review, but as I've indicated in the report, many of those themes are already translated into our work as a system, and you can see those coming through in the detail within the joint forward plan. More shorter term, the operating framework for 23-24. Again, we've got an item on this on the agenda. I just want to, at this stage, pay tribute again and thank ICB and system partners for their work on ensuring we've been able to develop a whole system approach to balancing our service commitments through the operating plan with how we've had to manage our resource allocation as well. And I say we'll touch on that when we get to that item on the agenda. Just a few director updates. So we have again over this last period closed the consultation with our own staff in the ICB, provided feedback and made adjustments to their responses around our future ICB structures, and have got on with the job of actually now populating those new team structures from April onwards. Really pleased that we've got to the point already that the majority of our existing staff have been kind of placed within roles, within teams, and we'll continue to sort of unfold that over the coming weeks and months as we again mature the structures and the team arrangements that we have within the ICB to service the work of the system. I think that also allows us now to take a key focus with our people over the next 12 months around the further development of our organisational development work and to build on our culture, values and the identity that we have within our teams around that the work that they do on behalf of the system. I'm really pleased as well that on the 20th of June in the afternoon we'll have our first ICB all staff event where we will be inviting all the staff of the ICB to come together face to face to both celebrate the work that they've been doing over the last 12 months, to recognise NHS 75, and also to recognise the first anniversary of the ICB coming into fruition. So really looking forward to that event. As Sim mentioned, I'm delighted that Nick Broughton is not only with us today, but will be stepping across and to take over from myself in July. And Nick will be directly involved leading up to that time in the recruitment to our remaining executive and director positions during the months of May and June. So really pleased to be seeing you come across into the role, Nick, and to support you in doing that as well. Just to finish with, under the quality and safety agenda, and I know our Chief Nurse and Chief Medical Officer may well touch on other aspects of this throughout the agenda today. I think it's important to really recognise the work of our local maternity and neonatal service. And I spent some time recently with the team who are fantastic. Really around the work that they are doing with partners in regard to our response to the 3-year single delivery plan published by NHS England at the end of March. This is really critical work across maternity and neonatal services that brings together a response to some of the key areas that we saw out of some of those really difficult to read reports in terms of Ockenden and Kirkup. So we're making sure that our citizens again are receiving the best care through maternity and neonatal services. So really pleased about the work that the LMNS are doing, again, in a true whole system approach. So Chair, I'll stop there and very happy to take any questions.
Thank you, Steve, and thank you for bringing out the, I suppose, continued progress of us as a system, because the question is, why do we exist and how do we add value? So we have to keep, I think, iterating and investigating and prodding ourselves in terms of our added value, and that convening role is vital. So let me open up, please, to any questions, thoughts or observations based on anything Steve has said. Any thoughts or any questions, please? Nick.
Thanks, Sim, and Steve, thank you for those kind words. I suppose how we add value is epitomised in part by the Education Forum next month, which I think is a really exciting event. And I suppose one of the things that sets our system apart from many other systems nationally is that we do have so many local universities that together train almost the full range of healthcare professionals. I realise there's probably some AHPs that we don't train. So moving forward, we should be able to develop our own workforce. So I think, trying to harness that potential of Reading University, Buxton University, Oxford Brookes University, University of Oxford, etc., and engage with them so we can help design the workforce of the future is a great example of what sort of system working brings to the table. So very much looking forward to that event.
Excellent, well said. Thank you, Nick. Yes. Any other thoughts or questions? Margaret.
Thank you, Chair, and apologies for coming in late. Really fantastic report, Steve. So good to start hearing about results and what we're doing and the impact now. 2 questions. It may be too early to say, but on the use of the incident structure for the industrial action and for the flood at RBHT, is it too early to say whether we've lessons learned or what we're looking into, how it worked and what improvements we can make through use? Because that is something that is different, isn't it, for the system? And likewise for the council elections, you indicate there was change of administration. Is it too early to say whether that changes any kind of direction or interaction with the ICS? Thank you.
Yeah, thanks, Margaret. I'm going to bring Matthew in and then Stephen in on both those questions. On the first one, I think it's probably just saying that the intensity of what we have collectively needed to address through a really difficult winter and then into a continued period of industrial action has allowed a huge amount of learning. And I think we have sort of learned in action as well as we've gone along with our partners to really sort of iterate how we look at a system response and the ICB's kind of role within that. So I think it isn't too early to say, really. I think we've been kind of learning as we've gone along and have undertaken a number of after action reviews already in terms of both the winter response, but also some of the kind of critical industrial action kind of responses, and how we've been able to sort of build our overall approach to those. But Matthew, do you want to say a little bit more? Then maybe Stephen, if you wouldn't mind coming in. I think I would feel a bit of a fraud trying to give a view when I've got a local government expert in the room.
Thanks, Steve. So yeah, just for reassurance, Margaret. So we do lessons learnt review on back of all the junior doctors, well, all the industrial action, and so we've got now quite a wide range of reviews and thinking around that. So there are lessons around sort of our incident structure and how we respond and work with a trust, but also I think in terms of working with the trust, the difference in approaches. So one example is at what point do you need to cancel operations? How do you manage that? So useful compare and contrast in that area as well to look at. On the RBFT incident, I think there's been a lot of learning on that around our incident response and where we are in terms of establishing our EPRR systems. So some really good questions which we've addressed already, actually. So really quick review, address and improvement on the back of that, because as you'll appreciate, in terms of our overall EPRR response as an organisation, as a system, that's still a work in progress in terms of all the paperwork, the information we have to the director on call team. So we've already learned some lessons and implemented some changes on the back of that. Happy to perhaps take an action, Steve, outside of this to where do we feed in some of that overarching narrative in our assurance structure. That's helpful, because I know that I think the audit committee is the owner of the EPRR standards, so it may be that on the back of that we can pull in a lessons learnt piece of work across all of the IA work.
Yeah, just to pick up, because I have already agreed with Alex that there's going to be you're going to do a 6-monthly report before we bring the next annual report to the audit committee, so it's already on the forward plan.
Perfect. Stephen.
Yes, thank you. So Stephen Chandler, local authority partner member. Short answer, Margaret, it is too soon to fully understand the impact of some of the changes, but clearly there have been some significant changes across the patch. We're still hearing from various councils what their configuration is, but also who will either remain as key portfolio holders for public health, for adult social care or children's, or where changes are occurring. So more at the next board, but exciting and interesting times.
Thank you, Stephen. We look forward to the excitement, definitely. Can I close this section? Any other? Oh, Aidan, please.
Thank you, Sarah. I was just going to make a quick point on the Hewitt report. Aidan Rave, Non-Executive Director. Steve, thanks for the report. Really, really comprehensive and helpful. It's interesting that the Hewitt report, a lot of the conversation and the chatter that's going on about it is what the government response will be and when the government response will come. And of course, that's really important. Of course it is. But I think it's important also that if we kind of look at the principles that the Hewitt report talks about, they're the principles that we want to follow anyway. They're the kind of the blueprint of what we've been talking about for 12 months. So I guess, and I'm kind of issuing this challenge to myself as well, is let's just forget a little bit about what the government responder says to some extent. We've got this in front of us. Let's embrace it and use it. It's exactly what we said we wanted to do. She's talked about a lot of the principles that we've already talked about. So, it's there for us to now, really start to accelerate with. So, I kind of think it's it can become an industry in itself, thinking about what the intrigue is and what the kind of ministerial response will be. It'll come at some point and it'll be what it'll be. But the blueprint's there for us to really grab and run with, was the point I wanted to make.
Yeah, Stephen Manus, Chief Exec. Totally agree, Aidan, and kind of just again reiterating, hold that in mind when we're going through the content of the joint forward plan. I think the only other thing to say is that some of the national debates and some of the things I've equally heard that has characterised the outcomes from the Hewitt review is there's a kind of potential pull within certain systems in different directions. There's a pull into some of the sort of NHS England operating framework work at regional and national level, so the aggregating pull, and then there's a pull to an extent through some of the language within Hewitt and Fuller into more subsidiarity, localisations, neighbourhoods. actually for us as a system, we're in a really positive place because we've explicitly founded the strength of the system on the strength of our 3 places, and within Berkshire West on the strength of our 3 local authority places that sit within that particular locality. So we've actively looked to add the ICB value at place as well as system, and to make sure that, as I say, we've got a vibrant place environment where, you know, work at neighbourhood level and the work that, you know, is talked about through the Hewitt review and the Fuller review can really be supported. So I think we're in a really strong position around responding to Hewitt because of the nature of our geography and how we have continued to support and invest in that geography.
Thank you, Steve, and thank you, Aidan, for that thought and question. It's useful. Oh, Saqib, sorry.
Thank you. Something I just wanted to say as we kind of approach the years from where we were incepted, though not necessarily formally as an ICB, is there was something talking about Scotland in the difference between communities that have deprived households. And it was saying, obviously, depending on how you measure it, if you compare one whole community to another community, there's been improvement, but hidden within that, there are deprived pockets. And I think as we, you know, work at place, we also need to be cognizant of that there are people that we need to target, you know, that are perhaps hidden within more affluent communities and really help those families as well.
Thank you, Saqib. And, you know, that's a challenge back, I think, to Rachel. And Rachel, as you talk to us about the health inequalities, and I know as a system, we are well aware that we have pockets of really, you know, overall as a system, we have a relatively healthy community and population, but we know there are pockets. And the key thing is to keep understanding how we are helping those particular citizens. And I know through Margaret's committee, that comes up often. So quite right that we should keep it on the agenda. Thank you. Okay, so moving on, performance and quality report, and this is a discussion, but presenting this will be our triumvirate, I think, Matthew Tate, Rachel Corsair and Rachel Decaux. And so we're to note the report, but we have focused on 5 key areas as requested at the last March board meeting. So there is a focus on the 5 key areas, but please, I'll hand over. Who am I handing over to first?
I'm going to start, Sim, if that's okay.
Okay, thank you.
So I just wanted to do a little bit on report development because there are some new sections in there that's worth noting, I think, as we continue to refine this. And then I'll talk a little bit about the urgent emergency care position, the planned care position and the cancer position. Then Rachel Decaux will pick up primary care and Rachel Corsair will pick up mental health and some broader quality issues as well. In terms of the report's development, just a couple of things I wanted to pull out. So we continue to refine this and get the balance between highlighting a small number of key areas as requested by the board, but actually make sure that there is broader information available across a range of areas. So you may note in this report that actually there's a bit more workforce information, I think, which is going to be absolutely critical in terms of our in-year reporting every board meeting through next year, and that will continue to develop. We've got some information on vacancies and agency spend in the report this time. The other area that I think is new and really interesting is continuing healthcare. So I think there's a nice summary of some of our continuing healthcare metrics which show the variation across our system on some of those metrics, which I think is something the transformation programme is looking at. And we continue to add information around some of the pod services we're looking at, including dental and a few other areas. So hopefully you'll get a feel for perhaps an expanded range, but still a focus on key areas. And those key areas, I'm keen that we review those going into the new year. So I want to have a look at the operating plan and the joint forward plan key deliverables and make sure that we've got that that meshed into our key performance areas that we focus on. But for this report, we've kept the 5 consistent now for a couple of months, but we will review that going into the new year. So briefly on some of our key performance areas, taking the report as read on urgent and emergency care, I think we have seen measured improvement in the 4-hour target performance. And it is important to remember that whilst we focus on that 4-hour performance, that is a relatively good indicator of the state of the urgent care pathway across the system, and it's much more complex than that ED measurement. we've seen some improvement. I think not perhaps the bounce back that we'd like to see. And if you look at the last few weeks, I think we're still struggling to get that momentum back up towards that 76% that we're targeting for this year. So we have got interventions across the system to try and support that. All three of our trusts are working on recovery plans, and we're going to use some of the time at our urgent and emergency care board to compare and contrast those plans. There is probably a more significant focus on Buckinghamshire Healthcare Trust. They are still in an oversight framework rating of 3, which is slightly enhanced surveillance, and they've got some really embedded challenges in terms of their ED performance. Lots of work going on in terms of capital expansions, new pathways, but a degree of work to do around that. But we're focusing across all 3 of those. There is a national oversight framework that's been introduced over the last year for elective and cancer, which is called tiering. That's now been introduced for urgent and emergency care. So the tiering concept is 3 tiers, with tier 1 being a national intervention, tier 2 being regional intervention, and we've seen tier 2 interventions in cancer across Bob over the last year, and tier 3 being slightly lower level support, but still a support offering around some tools and support. For our system on urgent and emergency care, we are in tier 3, but I think some of our performance comparisons, and we're now starting to understand the metrics used for that tiering, and they are focused on 4-hour performance, ambulance performance, and long waits in the A&E department. So that will be continued review, and we may at some point dip into tier 2 if our performance does not continue on the upward trajectory, and obviously we'll keep a close eye on that. But I think that in terms of our role, I think going back to some of the points Steve was making, we are keeping a close watching brief on all of our trusts. I've got support from both the Rachel DeCoe and Rachel Corser in terms of some of those interventions across staffing, workforce and quality oversight. And as Steve referred to, we've had the UEC summit to try and get some system momentum in terms of those interventions as well. So that's a quick overview on urgent and emergency care. On planned care, we continue to see good performance in terms of reducing long waits. We didn't quite hit our 0 target for 78 weeks at the end of March. That was impacted to a degree by industrial action, but also I think as I've highlighted the board before, there are a small number of really complex patients that do require more planning and do take longer to treat, and we've been gradually reducing those. We didn't quite clear all of those, and there is a national shortage of corneal grafts, which has meant that there have been some delays on particular patients. So we are still slightly over that 78-week target at the end of March, but actually our performance is good, and I think it's important to remember that we continue to reduce those long waits and have done since, if you look at the trend, which we'll focus on for this year, which is over 65 weeks. So some challenges, and we've yet to fully understand all of the issues around industrial action. There were a number of cancellations, so we're still working through the impact of that, but generally good progress and a good position going into the new year. Differential, as I think I've mentioned at this board before, in terms of the trust position, with Oxford more challenged in terms of progressing those weights and the capacity issues related with reducing weights than our other 2 trusts. So the last one I wanted to mention before handing to colleagues was cancer. We spoke a lot about cancer at this board, and generally our cancer performance is challenged, being particularly challenged around the 62-day wait target, and that's where earlier in the year Buckinghamshire Healthcare Trust were in tier 2, and Royal Berkshire Foundation Trust have also been in tier 2. So that's actually been positive support in terms of Thames Valley Cancer Alliance stepping in, offering focused expertise, waiting list review, but also targeted funding to support the improvement. And as you'll see from some of the graphs, we've seen some really good, solid improvement over the last few months for that 62-day target. It's important in terms of up-to-date numbers. We have seen some challenges over the last 2 to 3 weeks. So we've seen a gradual flattening and a small increase back of those waiting over 62 weeks. So we need to perhaps reset after the industrial action, understand the impact of that, and then continue to work with our trusts in terms of addressing the targets that we put into our operational plan and performance for 23-24. So that was a very quick run through of some of the key issues from that I have SRO's responsibility for. So I'm going to hand quickly to Rachel DeCo and then Rachel Corser to pick up a couple of wider points.
Thanks, Matthew. And I think just one other aspect from the cancer agenda is to note, Margaret alluded to the flooding incident that Royal Berkshire Hospital experienced last month. That did have an impact in terms of some of their mobile scanning capacity, so for CT and PET scanning, which is really important in terms of diagnostics for cancer pathways, and we will have to see how that impacts performance as the numbers come through. And they also had to move a number of their clinics and radiotherapy over to Bracknell in order to accommodate. So thanks, Matthew. Just moving on to primary care. So primary care, at the moment in the system, we have around 85.8% of appointments are within 14 days, which is above both regional and national average. And our total number of appointments are now above pre-pandemic levels, with face-to-face still remaining slightly below and any shortfall in telephone capacity. I think it's important to note that face-to-face is not always better for patients. It certainly is in some cases, but we need a range of modalities. And what's really important is what is the quality of experience that patients have when they're accessing primary care, which is why we've really started to focus on the friends and family responses. And over 90% have been positive, and they have doubled in terms of responses since January. I'd like to thank primary care for the immense extra support that they put in post-Easter and May bank holidays, and also in response to some of the industrial action. But it would be remiss of me if I didn't say that demand remains high. We're looking at the 23-24 contract changes, which clearly maintain the focus on access, really around making sure that patients are assessed or signposted to appropriate services at the first point of contact, that routine bookable appointments are able to be made within 2 weeks. All of our PCNs are submitting access improvement plans and maximising digital telephony and use of demand and capacity tools. We've made some really excellent progress in recruiting to our Rs roles, which are additional roles of reimbursement. So things like social prescribers, pharmacists, paramedic practitioners that work within primary care. And as I said, we continue to look closely at the friends and family response. Primary care isn't just general practice. So just to touch on dentistry, optometry and pharmacy, we have looked at some flexible commissioning to improve access in dentistry. And we've also had to scope some short-term capacity to meet some urgent needs of asylum seekers and refugees that have been accommodated within our system. There have been some handback of contracts from our dental practices, so we're keeping a really close eye on that to make sure that that doesn't impact access unduly. In the optometry space, we're increasing engagement so that we've got direct referral pathways into our acute providers to try and relieve pressure on primary care. And really importantly, certainly last but not least, community pharmacy, which is playing an increasingly important role in managing conditions that were traditionally seen in primary care in GP practice. We have an annual referral rate of around 721 per 100,000 patients, which is slightly more than the regional. And in terms of outcomes, around 45% of patients receive advice only, 26% get advice and medication, 10% of patients are escalated and 16% of patients are signposted, with a very small minority falling into other categories. So kind of a comprehensive view of primary care, and I'll hand over to Rachel Corser, but clearly very happy to take any questions at the end.
Thank you. Good morning. My name's Rachel Corser. I'm the Chief Nursing Officer here at the Bob ICB. So there's just 4 things I wanted to highlight from the report. The first is in relation to mental health. Colleagues will remember at the last board we touched on the work that we're doing to reduce the higher than we would want number of out of area placements for adult inpatients. Clearly it's a real target and a focus for us as a system, and we continue to work on that, and we have seen a slight reduction in the numbers of those inpatients in out of area over the last 2 months. Delighted to say that we kick off our inaugural mental health partnership board this week, and that's a convening of all of our partners that are working through both the children and adolescent mental health service provider collaboration, but also as we start to work on the new innovator provider collaborative that we've been successful with, and more importantly, how we then drive through the improvements and the transformations around our mental health services, and drive through some of those the targets that we want to see. So we'll bring an update on that in due course. The second area I just wanted to pick up on was the work that we're doing to develop our quality assurance and improvement framework. It was highlighted in the Chief Executive's report, but I think just important for us to note, particularly as we work with our colleagues at CQC on their key lines of inquiry, about how as a system we really monitor the quality and safety of the services that we are commissioning and responsible for. Delighted that we've worked with our partners to co-design the quality assurance and improvement framework. We're testing it through this Q1, and you'll start to see some of the metrics coming through in this report, but also coming through in our subcommittees. I think what we're starting to see is a real triangulation of some of the qualitative data, and you'll see here some of the patient experience data that's measured through friends and family tests, through complaints data. And at the moment, we're focusing on one particular lens through our trusts, but how we then do that more broadly across the wider system. And then how we look at that in collaboration with things like the mortality rates, the key quality outcome measures around harm towards our patients, and how we then use that to monitor our operational and performance metrics as well. So really delighted to see that we're developing that, and we'll bring that back through for further iteration through to board. Third area that you're seeing here is more detail around some of our infection prevention and control measures. And again, we're testing that as a pathway through the quality assurance and improvement framework, and happy to take some specific questions on that. And then lastly, as mentioned in the Chief Exec reports, and as Steve mentioned, we are working with our partners across the system to implement the single delivery plan that was published in March, looking at how we develop good quality metrics across the system, and working with partners to implement a system called Peri-Dash, so perinatal dashboard. That means we've got a consistent approach to how we measure and monitor maternity services across the system. So there are key areas I just wanted to pull out that are mentioned within the report, Sim. Thank you.
Thank you, Rachel. I wonder if you could address one of the public questions. Did you have that on your list to look at about the quality and safety framework?
I had tried to draw that out in my answer, so apologies, just to make that really clear. So yes, member of the public had asked us about whether it was available. As I think is in the Chief Exec reports, and as I've mentioned, we have developed the draft in Q1. We're testing it now with our partners in Q1, and it will be available and published next quarter.
Great, thank you for just clarifying that. Thank you, Rachel. Right, so quite a lot of update in that report, a sort of a romp through, but I hope you can hear progress being made and a clarity on the areas where we still need absolute focus to move that dial. So I thank you, colleagues, for the clarity around that, and I'm sure the public, especially Rachel, will be very happy to hear access points within primary care. So that sounds good. Shaheen. Excellent, thank you. Good to hear that from the ground. Thank you, Shaheen. Steve.
Just Chair, really quickly, I just wonder, Rachel, is it worth just acknowledging, I know there's more work to get underneath it, but acknowledging the well-trailed in the media community pharmacy kind of plan that
Absolutely
came out recently?
Yeah, so I think everyone would say the 645 million investment over 2 years nationally is extremely welcomed by community pharmacy. The service details and funding allocation is currently obviously subject to negotiation, including looking at the cost of IT integration in that. I think the funding is one aspect. We mustn't lose sight of the very real workforce issues that exist within community pharmacy as well as primary care, and I know that there are plans in order to address that. I think community pharmacy plays an important role in terms of common conditions that would otherwise be seen by a GP, but also in the prevention space. So, for example, in hypertension case finding. So really key. And with Rachel Courser's team and myself, we have sort of quality oversight and assurance of the referrals that come from our primary care colleagues in general practice into community pharmacy. So we've made sure that we have oversight of that.
Thank you, Rachel, for that sort of update. And I wonder if this is an area that we should probably bring back to board to get some more information and to give the public and the board more assurance about how that's being managed and the timescales and the reality of the progress. That would be great. Thank you. Margaret.
Thank you, Chair. A question on workforce and agency spend and the aspiration, the target of limiting that to 3.7%. I just wonder, in the light of pressures and industrial action ongoing and so on, how realistic that is and what degree of flex we're taking to that. And I'm looking at page 10 of the report on last year's level of agency spend among all the trusts. So it's a very challenging target. So what's the flex towards that target?
So shall I kick off and then Karen, you might want to come on. Oh, sorry, Steve. Apologies. I realised I'd main member of the board hadn't introduced themselves. Apologies for that. Matthew Tay, I'm interim Chief Delivery Officer, so apologies. So in terms of the reason I stepped in, I guess, was just to make the link to the operational plan. So we have seen a high spend on agency and bank, but we do have a very strong workforce piece of work led by Julian Ems as Chief Executive of BHFT to look at what we can do to reduce agency spend across the system. And it's been a key plank for trusts to look at their agency spend coming into this financial year and agree the reductions. And for those of you who read the operational planning paper, you'll see that actually overall, as a system, we are targeting to get down to that 3.7% that's mentioned on our page 10. I think it's probably fair to acknowledge that industrial action may have added some risk to the delivery of that, but I think it's clear, and we'll probably come on to talk to it later on the finance elements, that that close control, some of those initiatives to increase the substantive recruitment to reduce agency are absolutely critical going into the year. So all trusts are really focused on it, and we have a good system-wide programme as well. So happy for colleagues to add.
Karen, would you like to introduce yourself?
Yes, thank you. So Karen Beach, acting Chief People Officer. So not much more than Matthew's already mentioned. Obviously, to acknowledge it is a challenge, but I think the strength of what we have in the system is that temporary staffing programme. So really targeted sort of like interventions and looking at the data. So yeah, nothing more than Matthew's mentioned.
Tim, last question on this item.
Thanks.
Oh, and then Nick, sorry.
Thanks. Tim Nolan, Non-Exec Director. Just regarding the cancer performance, probably, I suppose, Director Rachel, within the detail of the 62-day number where we're not quite where we would like to be, but I know a lot of good work's been done. OUH's performance is particularly diverging from the rest of the patch. What sort of lies behind that and what's in hand to try and rectify it?
So I'm happy to kick off. Matthew will probably be able to articulate well some of the OUH challenges. So you're right to highlight it. It mainly focuses in three main areas at OUH around urology, gynae and upper GI. And there's a variety of different reasons. So some of it is access to diagnostics such as PET scanning. Some of it is simply surgical capacity. And in some areas, they are needing to recruit workforce in terms of consultants in head and neck and radiologists. So we are really clear on what pathways are affected. We work very closely with the Thames Valley Cancer Alliance in supporting our providers with kind of high impact interventions over those pathways. But I think it's fair to say we remain concerned about OUH as they are, and they certainly have probably been potentially more impacted by industrial action as a tertiary provider than some of our others. But Matthew may wish to add.
That's an excellent summary, Rachel. I think you're right. They're both workforce and capacity constrained in terms of some of the challenges around cancer, but they have committed as an organisation to hit the cancer targets going into next year and get those numbers down. But I think Rachel's quite right to say we know that the industrial action did hit some of that capacity, so we've yet to fully understand the rate of recovery they had put in place to hit the target for this financial year.
Thanks, guys. Just a quick second question, which was probably, I don't think it's Rachel or Nick, about the mental health numbers.
Rachel.
Okay. Regarding the eating disorders numbers, I know they're in red in the pack because there's been a data effect. And particularly the Oxfordshire numbers are very low relative to the target. Do we know that, is there any way of sort of stripping out the data effect to understand the underlying position? And if so, what is it? This is on slide 31, in the detailed pack.
So it's a question. The reason why.
Sorry.
Sorry.
Myself.
So just reiterate, Rachel Corser, Chief Nurse. So really good question, and there is still work going on around how we validate the data. As I mentioned, we've got our inaugural Mental Health Partnership Board where we're revisiting all of these metrics, because I think some of us will be aware that we've been reporting on the same metrics for a while, although some of it's been refreshed with the operational plan, and we'll revisit some of that. I think it's fair to say with the capacity challenges that we face around support for patients with eating disorders, this will continue to be a target that we will struggle to achieve, which is why it's important that we start to look at those measures again. Don't know, Nick, if you wanted to supplement that at all.
Yeah, I suppose it's important to highlight that certainly from an Oxford Health perspective, we have significant problems with performance reporting at the present time as a consequence of last year's IT outage. So it's taking us a fair amount of time to recover full performance reporting functionality, although we do have a plan in place now, which should mean that by the time the board next meets, the data should be far more contemporaneous than it currently is. And I suppose that was the point I wanted to make. So out of area placements is a really good proxy measure for system-wide mental health pressures, but the data we have before us today is 3 months out of date. And I think probably we can pull together more accurate data than that for next time, even if we have to do it by pen and paper.
Oh, good to hear. Thank you, Nick. I'll close that item then if no other thoughts or comments, and let's move on. We're going to go to Matthew Metcalf now for the finance report, if you don't mind, Matthew.
Thanks, Sim. So my name is Matthew Metcalf. I'm the Chief Finance Officer for the Bob ICB. The finance report sets out, I think, a financial situation at the end of the year, which is very much in line with the expectations were set at the last board meeting. The ICB was able to report a break-even position, very small surplus, but essentially break-even. And I think that was lines up with the plan that was set at the beginning of 22-23, so very much consistent with the picture that the board approved a year ago. In relation to the system, clearly there have been a number of challenges, but a position relative to where the system thought it was going to be is actually a slight improvement. The system reported a £30 million deficit, as opposed to the £36 million deficit that was in fact expected, forecast in month 10, predominantly because Oxford University hospitals were able to ultimately deliver a break-even position. The other providers essentially lined up with the forecast that they made at month 10. So all in all, a reasonable outcome relative to expectations sort of 2 or 3 months ago, albeit everyone will recognise that the 30 million deficit is not a position that anyone would have liked to have ended up at the end of the year. So the reasons for that, again, I think have been flagged quite strongly in previous discussions and meetings. Agency spend, as people would have to acknowledge, has been considerable over the course of the last year. In aggregate, £124 million, well ahead of what expectations might have been in the early part of the year. And Matthew has already referenced some of the work that's been done across the system to manage that particular position. Levels of spend to just meet overall demand have also been considerable, and albeit we've had extra income coming into the system, that has been offset by associated costs as well. People will probably note that extra income, £300 million for the system relative to the plan at the beginning of last year, or as it was set at the beginning of the year, which is also a significant increase, but much of that can be attributed to the pay award that was set through negotiation with government very recently and has been accrued for within that year-end position. Some of the 300 million can be attributed to additional system development funding that's been received, which, as the NHS is used to doing, often does come out of the blue, but most of it can be attributed to that workforce and the pay award. When we look at the ICB, we have delivered the bottom line against plan, which people will be pleased about, but at the same time, one has to acknowledge some of the pressures that have existed within our position. Again, well flagged, Matthew, Rachel and others have mentioned continuing healthcare. Those costs are considerable, even attributable to individual patients and their particular needs can be considerable, and steps are being undertaken to consolidate the management of CHC within the ICB, and through that process standardise and simplify the way that those needs are met across the whole of the ICS, and to begin to address the variation that Matthew again has highlighted in the earlier report, and we'll probably be talking about that again as we go through the forthcoming year to see progress. So largely to round off, I think a position that won't carry any surprises for anybody at this stage, but nonetheless does tee us up for some considerable challenges going through the course of 23-24. Thank you.
Thank you, Matthew. Yes, I just want to thank colleagues throughout the system actually, and all those colleagues in the ICB, to have delivered this under a really tough financial environment. So, and it will continue to be so. So really to acknowledge further work to be done, and the strength of the system as a whole coming together, working together to get to this position. Thank you. Can I open up any questions or thoughts on the financial position? Rachel.
I just wanted to see if it's worth just Introduce it. Good morning. So keen to talk about continuing healthcare. Hello again. My name is Rachel Corser, Chief Nursing Officer. I know Matthew just alluded to the work that we're doing on continuing healthcare, and just to reassure the board that this is an absolute focus for many of us around this table. Clearly, a big investment for the system, and I think the important thing for us now, and just picking up on your point, Chair, around the value that the system adds, that what we know we have is variation across the three places, and it's really important to us that that variation is reduced and we look at how we really instill best practice, but more importantly deliver within the financial envelope that we have to ensure that every one of those patients that are receiving continuing healthcare are getting it to the best value with the best possible outcome. So real focus for us, and we'll continue to report through both to the System Productivity Committee, but also our Population Health Committee, so that we can monitor the quality outcomes as well.
Thank you, Rachel. That's very useful. Rachel DeCoe.
Rachel DeCoe, Chief Medical Officer. I think just to build on what Rachel said, that as a triumvirate, Rachel, Matthew and myself have been constantly looking at and involved very closely with the financial teams, both in the system and in our providers, in terms of assessing the quality impact. So if there was ever going to be a situation whereby we may stop spending money on a particular service or area, that would not be done lightly, and it would be done with full involvement with our partners and with a quality impact assessment of that. That hasn't been necessary to be the case to date, but we have been very involved in the discussions from a clinical perspective.
Stephen.
Yeah, Stephen Chandler, Local Authority Partner Member. 2 points. First one is on continuing healthcare. Obviously, in local government, we've got lots of experience of trying to manage the cost pressures associated with very complex individuals, which happens to be where a lot of the continuing healthcare expenditure is. I was just wondering if any early indications of the risk associated with increased expenditure following the review has been identified, because there is an assumption that standardisation will reduce costs, when actually when we look at this, standardisation may actually identify costs or needs that aren't being adequately met and could result in an increase in cost. So that's my first question. My second question, just do both of them, and this one's for Matthew. I know it's early days, Matthew, so I'm looking forward rather than backwards, but in the last year you will have noted that we only achieved just over 50% of the savings plans as part of ALA. I'm just wondering if you've got any thoughts of what actions you would want to be taking with us as we look forward to ensure that our percentage of savings plans increase, our confidence around them increases from what it's been in the last year to what we need it to be.
Matthew, do you want to take Stephen's second question?
Should I do that? Yeah, so Matthew Metcalf, Chief Finance Officer of Bob ICB. Yes, thanks. Question, Stephen. Tricky one. The main shortfall, although not the only one, in relation to the savings requirement last year, was the £22 million that sat, as people are probably aware, in the ICB's books, that was system level savings that never particularly materialised. In fact, forget the particularly, didn't materialise at all. The response within ICB has been to pull together a dedicated team that will be working to me and with colleagues to support the ICB's productivity committee. At this stage, they have a very long list of opportunities. I think they're yet, in many instances, to translate themselves into fully fledged plans, but that is got a very keen focus on it through the course of the next 2 to 3 weeks, and how we actually can increase the level of assurance we can give to the board around that. I think we will be constantly looking at means of mitigating any shortfall against our savings plans. And the danger naturally with that is the degree to which we're able to deliver recurrent versus non-recurrent savings. But nonetheless, I think at this stage I can say that there is a considerable amount of focus being brought to bear on that.
Was there did you have your first question, was that addressed? The standardisation?
I'm happy to come in on that one. That's right. So I chair the operational groups even on a monthly basis that reviews CHC spends and looks at some of those comparators. Just to reassure you, yes, we're clearly aware of the risk of if we equalised additional spend across the system, because the variation is very big. So we've discussed the size of that risk in that operational group, and that's fed into the transformational board. So yes, we are aware of that risk, just to reassure you.
Thank you, Matthew. Okay, moving on, talking about risk, beautifully segued then. Catherine's going to talk to us about the board assurance framework and the corporate risk register review. So Catherine, over to you.
Thank you. So I'm Catherine Mountford, the Director of Governance. This is the first time the report with the risks has come in this format to the board. So with more detail on the principal risks, this was following our board agreement of those principal risks in January. So this report presents those. They are aligned to the 4 core aims of the ICB, and these will continue to be reviewed as we move to agreement of the joint forward plan and any refinement of or addition to core objectives and identification of risk. The other thing we have been focusing on is a clear line of accountability. So all of the principal risks are exec director owned. They report through the relevant assurance committees for that oversight, and the audit and risk committee at every meeting has a review on progress on the development and embedding of our systems and processes, and also the risks. As highlighted in the report, we are still reviewing and refining the next layer down of risks of the corporate risk register. So we now have directorate leads who meet 2 monthly as the operational risk management group and are working with their teams to do that systematic review, both for ensuring we're systematic in the way we score those across the ICB, but also it's not just identifying a risk. The key bits are what are the controls we've got in place and what are the actions we're taking to mitigate them, and how are we ensuring that they are linked both to what we're trying to deliver, but also linked across. And as has been highlighted by colleagues, as we manage the risk of managing within our financial allocation, we need to ensure that's not increasing the risk of quality or service access, and that's the triangulation we try and do through operational risk management group and also through executive. And then the last thing I wanted to highlight is we have had our first internal audit review of the processes, who gave us substantial assurance, but caveated by the points that was linked to the point of development we're at as an organisation. So we are delivering as they would expect us to do at this stage, but in year 2 it is absolutely about the consistency and embedding. So happy to take any questions.
Thank you, Catherine. That's clear. Saki, did you want to say anything or comment on anything at this stage?
I mean, as colleagues are aware, obviously the board assurance framework is a very important document to have high-level oversight of what's going on in the organisation. And the thing that I was going to actually raise on the last agenda item with the finances, I think working with our system partners, it's really important that we address both what's going on within the ICB, but also the ICS without replicating, because they're obviously sovereign organisations, but more as part of the movement to working more closely together, because obviously the financial position and the risks, as you can see on here, are very closely linked.
Thank you, very helpful. Any other comments with regards to the board assurance framework? Nick.
Sorry, forgive me, I keep forgetting to introduce myself. I'm Nick Broughton, Mental Health Partner Member. I suppose just an observation. you could say it's surprising that the workforce risk is the 7th highest risk rated on our BAF, whereas I'm pretty sure on all the individual trust risk registers it will be the top rated risk. So
Yeah,
perhaps to be discussed somewhere.
Catherine?
Yeah, good point. So actually, so Catherine Mountford, Director of Governance, thanks Nick. And I think it picks up on what you said and what Saqib says. I'm meeting with my colleagues from across the trust to start having that discussion about how are we aligning? Should the risks be scored the same or is it different? And then that moving into that balance of us managing our organisational risks and how we're working as a system to manage risks that are common to us all, that we might jointly own, we might want to score the same. We'll have multiple owners then, which we've got to understand, and potentially different actions. And I hope to start having those discussions with my colleagues in the next 2 weeks' time.
Thanks, Nick. Very useful. Right, colleagues, I can now safely say this is your comfort break time. Please could everybody come back into the room at 11:30 where we'll start promptly for the next session. Thank you.
Okay, I'll start. Again. Matthew Tate, Interim Chief Delivery Officer. So the paper you've got today is an updated operational plan, building on the paper that came to the March board. I will focus on changes in terms of the revisions since the draft plan. But before that, I did want to highlight actually that the plan is about service improvement. So across the range of national expectations and local plans, this is about improving services, reducing waits across the board, and addressing some of our key strategic priorities around health inequalities. So please take that as read, and I hope the paper outlines some of those plans clearly for the board. In terms of key changes from the draft plan, there's a couple of technical ones, so I will just highlight those. So when we look at our elective activity, one of the targets nationally is something called value weighted activity, which is, I guess, the cost base of our activity and the financial costs associated with that. So targets were set nationally around that particular percentage to try and encourage and push the recovery of elective care. And our target was 109%. So that's an increase above 100% of our baseline target. Our draft plans were about 95.4%. Our revised plans are 95.7 to 104.4. So that's a significant increase. There's a couple of things I wanted to pull out about that. We were an outlier on our first draft plans, and we've reviewed that both from a technical perspective and an actual activity perspective, working with our trust. So we have found some technical areas where we could adjust the baseline, or that the entry in terms of the technical submission wasn't quite right or can be amended. We've also seen some increased activity, particularly at the Oxford University hospitals, to increase our value weighted percentage. So that's a big improvement and a step towards the 109%, but we are still well below the 109%, which was the national target. So that's one of the areas we've been reviewing with the NHS England team. The reason it is important is that it is associated with a large sum of non-recurrent money in the system called the Elective Recovery Fund, which Matthew may refer to later. But if we don't hit the national target, there is an argument that may say that all of that funding is not safe. So that's a risk that I'm sure Matthew will mention later. Dementia diagnostic rates, we've now developed a plan that is compliant with the target. Our cancer performance has improved from our draft submission to our final submission. We've still got one trust that doesn't feel it can reach the target recovery for the 62-day wait, and that's Royal Berkshire Foundation Trust. We will continue to work with them to see if we can find a way to get the capacity to deliver those targets, but at the point of submission, we weren't quite there. So workforce numbers have also changed marginally overall, but a couple of points to pull out. So I think we highlighted at the last board that actually we have some workforce growth, but it's quite targeted. So it's targeted around the mental health investment standard and the R's role that Rachel Deco referred to earlier. Our acute trusts are now generally flat or slightly reducing their workforce numbers, and we've included a little bit more information in terms of those workforce changes over the year, and you can see that the average rates the average rate of growth is slightly lower than the actual comparison of staff in post at the end of 1 year to another year. That's in tables, table 3 and table 4 in the paper. In terms of the financial plans, I will pass to Matthew to outline that in a moment. But from an ICB perspective, we have submitted a break-even plan that came to the last March board, but I will ask Matthew to give a bit more context on that. So that's really just all I wanted to say, Chair, in terms of an update from the initial plan that we submitted and brought to the board in draft form. So I'll hand to Matthew if that's okay.
Thank you, Matthew. Matthew Metcalf, I'm the CFO for Bob ICB. Just picking up on the financially related issues that Matthew's just brought to our attention. The first important point is that the system plan, and indeed the ICB plan is now at the point where we've got approval from NHSE. So that's taken quite a lot of work to reach that point, and the overall position leaves the ICB at break even, as approved by the board at the last meeting, and the system at a £20 million deficit. That 20 million is spread largely across the acute providers. In relation to our own position, the difference between the position in March and the position now is essentially one of risk. So we have taken on more risk within the ICB, which we are confident of mitigating, but it is going to take quite a lot of work to achieve that. So the way I'm looking at that is there's an additional 7 million, which is split between a couple of areas, but we're working out the more detailed plans in terms of how we gain greater assurance that that can be delivered, and we'll be keeping close attention to that through the course of the year. Closely associated to that will be the level of controls that we'll want to impose across the organisation, again, which will need to be tighter than perhaps we've been used to up until now. Looking at it from a system perspective, the previous system deficit that went into NHSE that the board will have seen would be £87 million. So to get that down to 20 million has obviously been quite a considerable effort. A lot of that has been by pushing additional savings requirements onto the providers themselves, but not exclusively. There's certainly been reallocation of income towards things which would have otherwise been in people's plans in any case, and there have been some technical means that we've been able to use to capitalise costs that up until now perhaps we've assumed were going through our income and expenditure. But crudely speaking, we've reached the point of a £20 million deficit that has had the benefit of a £22 million extra funding line from NHSE itself, essentially to underwrite the non-pay inflation pressures that existed at the time that the original plan went in, and was really the predominant reason why the system was planning on such a large deficit. It was coming through the level of funding we were receiving relative to the amount of non-pay inflation that we considered was likely over the course of this coming year. So that's the broad picture. ICB consistently with a break-even, consistent with what's previously been approved, and the system at a £20 million deficit, a considerably better position, I think, than overall, at least, relative to where we were at March.
Right, thank you, Matthew and Matthew. So what we're hearing is a sort of a continued focus on the areas that we're already focused on. We're not bringing in new targets here operationally, and the continuation of that tough financial environment, and actually, you know, looking to the system to really help our partners get to these savings that we need. So we hear you, Matthew. Tim.
Thanks, Tim. Tim Nolan, Non-Exec Director. Main questions for Matthew here. The ERF, the Elective Recovery Fund that Matthew Tate talked about. If we only hit 104% of the weighted target, Matthew said there may be a risk. What's the scale of that risk if we were not to get that? What do we have a sense of how much value? A second question, which relates to this is for the year we just started, this plan. My understanding is that some of the conversations with NHS about this is a glide path to a full break even next year. Is that, obviously, if we get the 22 million, we'll be breaking even this year. How confident are we as a system with the other CFOs about the 2-year horizon?
Okay, Matthew Metcalf, CFO for Bob ICB. In relation to, just as a point of correction, Tim, the system plan will be a £20 million deficit, not break even, just for clarity. ICB will be break even, even if we get the 22. So in truth, some concession there, I think, from NHSE, but that's just a point of clarity. In relation to the risk related to ERF, it's just shy of 70 million quid. And we are working at present on, well, as Matthew's highlighted, the actual percentage of value-weighted activity that is in our plans now at about 104% relative to the 109. I think we all understand that, but that puts us in the middle of the pack. By no means the worst. So this is a risk that sits now across certainly the southeast, but practically speaking across the whole of the country. And therefore the reality, we believe, is that they would be very unlikely to take that money away from us through, or if we fell short significantly of the 104%. Nevertheless, it is still a real risk, and we don't know how that's going to mature. So there's a bit of quite a game, but there's a risk to be managed, I think, through the course of the remaining of the year. Second point then, relating to sort of break even next year, I think there are, this is probably the biggest risk I suspect for us. There is no clear plan yet as to how that can be achieved, and I know there's different views around the various providers as to the practical steps that will need to be undertaken in order to get to that point. But taking both the Joint Forward Plan, which we'll touch on in a moment, and secondly the BAF highlighting some of the work that needs to be done over the course of the next 3-4 months, we need to develop that view to gain much greater assurance that that is at least possible, even if I think it's likely to remain a significant risk throughout the remainder of this year until we've really bottomed out our plans.
Thank you, Matthew. And any other questions? I don't know who was first, so I'll take Margaret and then Saqib.
Thank you, Chair. An observation actually on the shape of the plan. I'm so pleased to see health inequalities and the focus on prevention right at the top of the plan. You know, this is one of our core aims as an ICB ICS, and it's really great to see it up there. So thank you to the team for giving that as our first focus. And then a question, it kind of links with the JFP, I guess, but to the 3 place examples are so interesting. And I was hoping that we'd have opportunity to have interaction to share those with the board, and also to ask if there are opportunities across the 3 places. Are those projects and pilots and so on, are they learning from each other, and do they have the opportunity to share with each other? So more exposure to place, I guess. And just a question, it's my maths, but on the elective issues, the 10,000 anticipated increase in the elective care numbers, so around 8%, right? And then the ambition to reduce the long waiters. Can we accommodate both of those? Or are we just having new long waiters coming in a year down the line? How does that work? Thanks.
Yeah, happy to take the inequalities question. So myself and one of the directors of public health co-chair prevention and inequalities group, which has representation from across all 3 of our places, both in terms of place directors, but also in terms of providers, voluntary care sector, patient representatives. So we have a forum by which the plans and progress of plans are shared and monitored, so that there is that exchange of learning that then reports through to Population Health and Patient Experience Committee in terms of how it then moves on up to board. But there absolutely is that opportunity for cross-fertilisation, if you like.
To add anything?
Yeah, I think it's a very good challenge, Margaret, on the electives. So yes, I think that's one of the challenges. So yes, it is possible to grow a waiting list and reduce long waiters. Absolutely, that's about prioritisation of treatment. but I don't think it feels desperately satisfactory. So it is something we're going to look at. The increase in waiting list is mostly at Oxford, and so we're going to work across the system and share how we review our waiting lists, how we manage those waiting lists, and how we validate to a degree those waiting lists, because we have seen reductions in some parts of the patch through sensible review, validation, making sure that you've got the right cohort on that waiting list. So I think it's a really important strategic question. Are we, we know that we're very good at addressing long waiters, and we can see progress on that, but how much of a sustainability issue are we building up behind that in terms of the overall wait list? So a really important issue. We're going to get into the detail of that as we go through the year, but I am confident that actually the trust can target the long waiters, but it's about the long-term issue that I think we've got to work.
Thank you for unearthing that, Margaret. Saqib.
Thank you, Saqib Ali, Audit Chair. So I just wanted to understand the differences between Table 3 and 4 on page 82, 83, I think it is. So on one, we've got headcount going up, and we've got on the other, we've got headcount going down. And no one is actual staff at year end in March, and the other is average staff. So I guess it's the difference between where we are today and by the end of the year. So I wanted to understand, A, with the cost challenges we have, how we can afford to increase the number of our staff. Is there extra funding coming in, or is it offset by the reduced spend that will be on bank and agency? Because in the kind of current financial climate, to be adding staff, whilst obviously we want to do the best by patients and achieve all our clinical targets, it just seems a difficult dilemma.
I'm happy to kick off that. Colleagues may want to come in and support me as well. So I think primarily where we have workforce growth, which I tried to pull out in the report, is where we tend to have ring fence, for want of a better description, ring fence money. So particularly the R's role, that's a ring fence sum of money to recruit to. The mental health investment standard is not completely ring fence, but it's targeted to improve a range of mental health services that require workforce expansion. So outside of those two areas, you can see that the workforce is broadly flat. In terms of the differential, I deliberately put the tables in because it does show, I think, that actually quite a lot of our recruitment is backloaded towards the end of the year in one or two particular trusts, because actually you can see that the averages go down, but actually if you compare start and finish point, you've got an increase in trend. So I guess that is also about financial management throughout the year as well, in terms of when we recruit and when we can afford to recruit. But happy for colleagues to add context or detail to that overview.
Rachel.
Yeah, just to support Matthew from the R's roles perspective. So as you said, those are ring fenced and they are critical to support resilience in general practice. They drive innovation, they drive quality and reduce innovation, they drive quality and reduce variation, they support the inequalities agenda. They've also, for example, been pivotal in delivering vaccination programs. So really, really important, those are ring fenced, and that's where you're seeing predominant workforce growth.
Sorry, just before I bring Nick in, did you want to come back on anything, Saqib?
It was just to say that I guess if there was a column with vacancies, that might help, because if we're filling the vacancies that are already there, then I guess you'd know that potentially we're spending money on bank or agency today.
Sorry, before Nick comes in, fair point. I guess that I may take that back to my performance report challenge of how we report workforce, because obviously you do see vacancy rates in that report, so key to give you some context.
Got it. So just managing those interdependencies. Thank you, Matthew. Let me just bring Stephen before I bring Nick in, because I think it's the same point.
Yeah, so we're looking at this in the context of a flip over from 22-23 into 23-24. But actually the key line of inquiry for us in terms of workforce and thinking about this year, but sort of sustainability of service, workforce and financial resource is actually the workforce growth from 1920 through over the last 4 years. So this isn't specific to this system and our providers. This is across England that we've seen a significant workforce increase from 1920 through to 22-23. Again, there's generally outside of primary care and within the mental health investment standard, kind of where targeted workforce growth is funded, we're trying to flatten out some of that workforce growth and really focus on how we can support providers in that transition into substantive appointments rather than flexible labour and agency costs. But actually getting underneath that more significant workforce growth within our providers, particularly our acute providers, over the last 4 years, is going to be one of the key issues for us, say not just this year, but over this year, next year, in terms of that financial sustainability and getting that balance right. And that work is underway both through the work that we've already alluded to in terms of Julian Ems leading on that agency programme within the system as one of our system-wide kind of efficiency pieces of work, but also individual organisations have got a significant level of workforce data around that growth, broken down by particular professional grouping, and we're going to be supporting them in terms of getting underneath that, particularly where there are opportunities to, let's say, translate that into substantive kind of roles and reduce the cost of labour in terms of agency costs.
Nick.
Thank you, Nick Broughton, Mental Health Partner Member. I suppose stating the obvious, delivering this plan is not going to be entirely straightforward. And with that in mind, it may well be a reflection of the national guidance, but I can't help but think that there needs to be a greater focus on what we can do in the community space above and beyond virtual wards, because in ED performance is not just about flow through the acute hospital, it's about stopping people going to ED in the first place. And I think there's a huge opportunity for us to develop more proactive community services, for example, looking at how we support people with cardiac failure in the community. So as of 3rd of July, I think that's something I'd be really keen for us to look at, because we have to be transformational and radical in our thinking, I think, to put things on a more sustainable footing, not just this year, but beyond.
Thank you, Nick. Any other comments or questions on this piece? Then in that case, then can I ask colleagues, are you happy to approve this operational plan, with the proviso that obviously the work continues, and we'll take into account what Nick has said on that community space? Everyone happy to? Thank you. So that's approved to take forward, Catherine. Let's move on. A joint forward plan, and I feel as if we've been, Rob, you seem to be a constant in our midst, which is a good thing. Your joint forward plan, our joint forward plan, has had the airing that it needs and has been through many, many colleagues. So you are finally bringing this back for approval. So please update us on who else has commented and what you've been doing since we last spoke to you.
Good. Thank you, Chair. I'm afraid this isn't quite the last time. So what I'll do a little bit about just reminding very quickly what the purpose of the joint forward plan is. I'll do a little bit about process in terms of where we are and what we've still got to do. And then I'll sort of come back to how we've been engaging with people, what we've heard and what we've reflected in what we have circulated and shared today. So just a reminder of the joint forward plan and its purpose. So it is a delivery plan, and importantly, it's about trying to balance it's setting out a 5-year plan, and so that 5-year plan is by nature balancing the operational requirements that we have in the short term. So it's helpful to have had the conversation that we've just had, but really importantly, it's picking up the ambition that we've got that's been set out in the integrated care strategy. So some of those ambitions that we've got around prevention and inequalities are absolutely at the heart of what we're trying to get done through the joint forward plan. The other thing to remember is that this is a plan that is owned by the ICB and NHS partners across the system. So therefore is reflective of 7 organisations formally. So there's a process that we need to be going through with all of those organisations. Just in terms of how we've developed it, important to remember that this has been a collaborative development. It's not something that the ICB has done in isolation, but again, the process that we've been through has been engaging with other colleagues, understanding what their priorities are, reflecting on the engagement that we did through the integrated care strategy, and hearing what members of the public and our communities wanted to see prioritised. So it's been a collaborative development. And yeah, lastly, just in terms of that sort of overall, this is a document that should be really setting a direction for us for the next 5 years. So that's really what the joint forward plan is for. In terms of process, we have, so the last time that this joint forward plan came to the public board was back in March. We didn't share lots of the detail at that point. We shared sort of an outline of the structure. Since then, the document has been in the public domain, and I'll say a little bit more about that. But we're at a stage now where we are seeking endorsement from the sort of formal members of the NHS organisations that will own the plan. So I've listed the 6 other organisations in the paper, and then the ICB is the 7th. So we've got all of the NHS trusts in the patch, SCAS, the South Central Ambulance Service, and the ICB. We're asking each of those organisations through May to endorse this version of the plan so that we have something that we have agreed to before we go into June. And in June, we are asking health and wellbeing boards across the patch to review what we're proposing and to comment on its alignment to the joint health and wellbeing strategies that each of those authorities have. So there's a process that we'll be going through in June, and we want to be confident that we have the endorsement of NHS organisations before we go into that process. That will allow us then to have a version that we will have system sort of ratification for that we'll publish at the end of June. But why I say we're not quite done as a public board is because we will be asking the public board to formally approve this in July. Hopefully by then it will have been through everybody, and so that will be a straightforward process. So that's a little bit in terms of where we are. Just to update the board in terms of the content of the plan, because that's really the important bit. As colleagues will have been reading this through, you will have noticed that there are really 2 parts of this, so that there is lots of detail that sits in terms of our delivery plan. It's really important that we've got that detail there, because that sets out some of the ambition that we've got for specific services. And those are the services and the delivery plans that are really aligning to the integrated care strategy and some of the specific ambitions that were set out in the integrated care strategy. So there's lots there. I'm not apologetic for it at all, because it's really important that we set out what that ambition is and what that detail is. What we have included is 4 areas of challenge that we have identified across the system, where we know that there is work that we need to be doing as a system, as a group of providers, both NHS and with our other partner organisations. We need to be working together to address those challenges. And what we've done in the plan is to prioritise really one single response that we want to focus on in 23-24 for each of those challenge areas. And the reason why we've focused on that one thing particularly is so that we are realistic in terms of our ambition. Those are things that should set a really clear foundation for us as we go forward into subsequent years. Just to be clear on what those are, Chair. So we identified a challenge of around inequalities, and we recognise that there is work that we're doing, but in order for us to do that even better in years to come, we need to put real emphasis into making sure that we are maximising the opportunity of population health management. So there is work that we need to do around making sure that we have that integrated data set, but then really think about actually how are we going to be using that integrated data to inform decisions that we're making about where we prioritise our resources. We identified a challenge that we've called the model of care challenge, but essentially it's trying to understand how we can do more to keep people well in their communities for longer. And the single action that we've identified there as a priority is to be very clear about what our model of care for primary care will be, and how that model of care will be integrated with other organisations that are working in the community. The third area of challenge was around people's experience of the services that we are providing, particularly a poor experience, but where we've spoken around weights and access. We've touched on that in terms of the operational priorities, and the activity that we are proposing there in the joint forward plan is doing some work that's very focused on specific pathways, looking at demand and capacity, and trying to understand how we could do more, particularly taking a preventative lens on demand, and then thinking about capacity and how we might use our capacity as a system differently. Lastly, we had the challenge of sustainability, and there we've looked at financial sustainability and the challenges that we have around workforce. Again, those are things that we've touched on, but the real emphasis this year about making sure that we have those long-term strategies or long-term plans to address the challenges that we've got there. So that's where we've got to. We're asking for endorsement that those are the right things for us to be looking forward to, but happy to take questions.
Thank you, Rob. Very clear. We know what we have to do. And I'm just really pleased, actually, from the 4 challenge areas that they're all, it goes back to Nick's point about prevention and changing the way that we do things in order to stop people ending up in the acute setting. So, you know, we really have to focus as an ICB going forward on the prevention and promotion of health in community. So I'm really pleased to see that. So let me invite colleagues, any questions, thoughts for Rob on this new sort of iterated, updated version? Rachel.
Thank you, Chair. So Rachel Corser, Chief Nursing Officer here on the ICB. We had a question from the public ahead of board regarding our emphasis of quality and patient and staff safety throughout the JFP, and asking whether we felt it was strong enough within referenced in the report, and just to confirm that there are a number of areas where we reference the work that we're doing around developing our quality strategy, and as I've discussed earlier already this morning, the work we're doing on developing the quality assurance and improvement framework, and how we link all of that through improvement, research and innovation. So it's referenced in a number of areas throughout the JFP, and we'll continue to work with colleagues on doing that triangulation between the operational oversight and the quality and safety of our patients and staff.
Thank you, Rachel, for addressing that. Any other comment, please? Aidan.
Thanks, Chair. Aidan Rave, Non-Executive Director. Rob, thank you for sharing the update on this. Really great to see, actually, and it makes me think that one of the things I think that ICBs generally have been struggling with, and we've certainly talked about, is that kind of sense of identity. You know, this really starts to frame that. It puts its arms around it. This is us. This is now, you know, our kind of clear plan of what we want to do. So it's great to see it. Great to see it in front of us. I think it's also useful as a kind of a framework to guide our work for the next 12 months and indeed beyond. But I think specifically, one of the challenges that we need to meet within it is what does this actually mean in place? It was Margaret's question earlier, you know, and I think that's something we really need to get stuck into in the next 12 months, you know, and I know system and place and system development committee, which I chair, you know, part of what we're doing is deep dives into place, and it'll be really useful to use this actually as a kind of guide in that. I think the other thing that just struck me as maybe a thought, of the 4 objectives that ICBs were presented with when they were inaugurated last year, I think one of the ones possibly we've struggled most with is that kind of wider impact, wider regeneration point. And I think we need to start to think in the next 12 months about how this plan plays to that. I think there's a real opportunity for us to do some interesting work in that space. And I think we probably need to wrap that challenge around, you know, how does this work in the short term? But just really, really pleased to see this. So thanks, Rob.
Thank you, Aidan. Very, very helpful. And I particularly like that wider impact. We mustn't lose sight of that as one of our core objectives. Thank you. Any other thoughts before I bring Steve in? Matthew.
Thanks, Tim. Matthew Metcalf, CFO of Bob. it's probably an obvious statement, but the overriding goals of the JFP here do have some considerable dilemmas within them, not least a very obvious tension between delivering our goals around inequalities and the model of care challenge, and sitting in tension with the financial sustainability challenge. I think that's most obvious when you think about trying to create an environment where we increase our resources within community type settings in order to achieve that model of change that we're looking for. Yet at the same time, intuitively that implies some double running, for example's sake, or some extra income to be found that presently isn't in our allocation. So I think there's a lot of work to do to be able to validate what it is that we're trying to do strategically, which is clearly the right thing to do, with the financial plan that sits alongside that. And I know that that feeling is sort of felt across the system.
Thank you, Matthew. One thing for sure, we won't be able to do this alone. So that weight, if you like, of burden, this is where we all need to pull together, and it's going to be difficult, but this is why we're here. Tim.
Thanks, Tim. Tim Nolan, Non-Exec Director. Thanks, Rob. Very much echo Aidan's points about it's great to see this in a almost signed off form, and I know a huge amount of work's been put in by you, but also huge amount of participants and partners both in the NHS and beyond. I think it's a great document. My only comment really relates to the point about are we nearly there yet? And I think on the basis that it's a 5-year plan, I think it's a bit like the Forth Rail Bridge, that once you finish this bit, we need to start next year's immediately, because the one thing we've not had this time is the luxury of a full year to plan, because all the people have been coming to their new roles and so forth. And I think when we iterate this next year, I'd hope to see a bit more about years 3, 4 and 5. There is some in here, I'm not saying it's not here, but a lot of what we want to do and the stuff that Margaret and Nick have talked about really challenging the inequalities agenda and doing things differently, and Matthew mentioned it a moment ago, double running, some of the difficult stuff there, is going to take a lot of planning, and it may only come to fruition in years 3, 4 and 5. And I think to really move the dial on this stuff, we've got to start like immediately thinking about this as soon as this gets signed off in July, if not before, because I think it is to use another analogy, it's an oil tanker, you know, to turn this round or to change the direction. So that would be my only comment.
Sorry, do you want to? No.
Should we let Margaret come in and then I'll reply?
Okay, yes, that's fine. Margaret, then Ross, and then
Thank you, Tim. Thank you. Margaret Batty, Non-Executive Director. I think it shows the how valuable this plan is, that it's kicking off conversations and thoughts, and I fully endorse it, Rob, and the team that's got us to this stage. So it's kicking off thoughts for me. Just based on what Tim was just saying, actually, it's the years 2, 3, 5 are inevitably quite thin. So looking at the inequalities, for example, inequalities in prevention, we have this allocation of 4 million for this year, 4 million for next year, and then 4 million for the 3 years following. So what I would like to see, ideally, and that's right, isn't it, Rachel? 12 million over, or is it 4 million a year? So we know.
Apologies, Rachel Coe, Chief Medical Officer. So we know that we've got 4 million per year for the next 2 years. We do not have security of funding continuing from there.
So ideally, we hope we have years 3 to 5. But what I would like to see, whatever the figures are, and they're paltry compared to the challenge that we face, will we be able to produce some kind of forecasting as we get population health management data through to say what is required? You know, this is the scale of the challenge across Bob if we want to tackle inequalities and focus on prevention, and what's the price tag of that? And I know it's a very idealistic notional figure, but 12 million or 4 million or 8 million is not it. So how far off, you know, is that? We're grateful that we've got 4 million for the next 2 years, but it's not enough. But I don't understand the scale of the problem, what it would take. What are we effectively lobbying for? And what it's also helped me do is to try and tease out the difference between tackling inequalities, focusing on prevention. They're not always the same thing. Often they're interlinked, but often they're not. And the use of population health management data. And I think that there's one sentence in here which says some decisions may benefit some communities more than others on page 218. That's a loaded sentence. So, you know, when does the rubber hit the road? When do we and partners start to make those decisions and have those conversations? Because if we focus on use of alcohol in middle class communities across Bob, that's a very different proposition to focusing on populations in Reading not taking up diabetes checks and so on. So that for me, you know, this is the entry point for us, but some very difficult conversations to come and decisions. Thank you.
Thank you, Margaret. Let's continue round and then you can respond. Ross and then Saki.
Yeah, thank you, Ross Fullerton, Chief Information Officer. So, and in some ways it builds upon Margaret's point about this being used, because I think it's an extremely useful document, and it's as we get into talking later on the agenda about the digital and data strategy, you can see the links in between the two of them. And the test for me of this is not just use in this room and around this table, but actually across the NHS bodies that the joint forward plan represents. And I think the test for me is how, if we were to talk to leaders and staff across our NHS partners, to what extent does this feel real to them yet, and something that informs their decision making and the choices being made versus being a bit of shelfware. And I think that's a question we should come back to as a board over the next few months, as to, once we've approved this, how are we seeing it being used in genuine decision making across the system, and what other work do we need to do with those partners to ensure that it lands in a meaningful way that supports those interventions in the future.
Thank you, Ross. And Saqib, and then finally Steve.
Thank you. Saqib Ali, Non-Exec Director. So I just wanted to say, you know, great document. I think, you know, it has all the aspirations that we're trying to pursue on communication and getting buy-in with our communities, especially out of not in English. I think we need to make sure that as we progress, we get simple versions of this, like a one-page bite-sized videos, etc., so that both at the ICP level with, you know, elected officials, but obviously our communities and residents, they can buy into it, they can understand the direction of travel that we're going for.
Thank you, very useful. I think one of the comments back has been the length of the report, so we take that on board. I think, Rob, you've taken that on board. So let me ask Steve now to try and pull together some of what we have the wonderful task, but you are the CEO, of pulling some of the thoughts and strands together, and then we'll finish with Rob, and hopefully you'll get your endorsement.
Yeah, thank you. Again, I'd like to thank Rob specifically, and obviously working with other colleagues, but a huge amount of work. And I talked at the start of my CEO report about laying the tracks down. So this is really laying the tracks down, and you know, it's great that we're having this sort of discussion, but we're having that sort of discussion because we can start to see how some of those tracks are sort of playing out over the next period. So just a few things. So to Tim's point, let's just keep in mind that by the end of June, we're 1/20th of the way through. So this is a 60-month programme, and we'll be 1/20th of the way through by the end of June. So we've just had a conversation about 22-23. This is year one. So when we're thinking about this year, we need to be thinking about what we're doing this year in the context of this plan. So I think that's really important to hold that. Great, like Margaret said, to see both how we've kind of focused in terms of this year's 23-24 plan, but also in this about our ambition around health inequalities. I think it is really important to recognise, and I'll come to my third point, that actually there's already a huge amount of work in the health inequality space within the core funding, not just this 4 million plus the 4 million next year. So I know we talk about that being a paltry sum, but I know within the core allocations that we've got across health, and Stephen, I think within local government and within primary care, the day-to-day work around our communities where we've got higher levels of health inequality is already activated. One of the things we need to draw out, I think, more is and amplify is where more of that work is taking place, and the quantum of that kind of work in terms of our 3.2 billion health allocation that we've got within this system. And it comes to the third point, which is, you know, in the way that the slide where we've got the biggest system challenges, and we've talked about what we want to achieve around reducing health inequalities, getting people healthier for longer through earlier intervention and prevention, increasing experience through access. The three of those really important ambitions are underpinned by the fourth, which is about our sustainability of resource. Now, I think Matthew rightly talks about some of the kind of challenges in that space, but I think we need to bring together particularly the financial allocations and the use of our financial resources and our people in terms of instead of thinking about an LTFM, a long-term financial model, we need to think about an LTRM, so a long-term resourcing model, where it's actually about the application of the broader resource we've got over the next 5 years towards service intervention that is actually about that earlier intervention prevention work. So if I just take going back to the Royal Berks, which I will be in July, so the Royal Berks consumes about £550 million worth of public money from within the system to deliver health and care services. So part of our challenge at the Royal Berks is to increasingly over the next number of years is to reposition more of that resource towards this agenda. So how do we start in the areas of long-term conditions, in the areas of cardiac care, move the resource that we have within the core funding in the Royal Berks to work alongside primary care, to work alongside local government, to work alongside our local communities. So there's actually more of that expertise is supporting the earlier intervention work, the work on health inequalities, the easier access and improving experience. So it may not be that we're kind of shrinking one part of the sector to increase another, but it's about the LTRM in terms of how we're utilising the totality of that resource against this agenda. So I think that's where we have to draw out, Matthew. I think the challenge is within individual organisations as well to get their head into that space. And our sort of challenge is, as an ICB, is to help them do that over the next period. But let's keep in mind that we're 1/20th of the way through. So time is of essence.
1/20th. Rob, would you like to have your final say?
Well, so thank you all for the feedback and comments. This has been a team effort. It's certainly not only me. There have been lots and lots of people that have inputted to this, so thanks to them. Steve, you picked up a few of the things that I was going to say anyway about actually how we do that, the importance of really trying to continue those conversations, but actually accelerate some of those things. Totally recognise that the focus is very much on this year. This is the first year that we've written the plan, and there are some foundation things that we need to get right. So there is more that we need to do about trying to understand those tensions, how we might start to make some of those shifts. That requires ongoing conversation with our system partners about how we might achieve that. And I'll stop there, as in there are specific things, but I can pick those up, I think. Thank you.
Thank you, Rob. So asking colleagues today then to endorse this particular version of this joint forwards plan, you know, following the discussion that we've had, and it's been a good discussion. So thank you, colleagues. Really good discussion. Yes, I think I'm getting nods all round, Rob. So well there you go. You get to your next version. That is your prize. the next one. So thank you. Moving swiftly on, a little bit over time, digital and data strategy. And again, we're looking for approval for Ross on this particular strategy. Ross.
Thank you, Chair. Thank you, colleagues. So Ross Fullerton, Chief Digital and Information Officer. And I'm really pleased to present in front of you the final draft of this strategy for approval. And just reflecting on that last discussion about system challenges and the JFP as they're set out around inequalities, model of care, experience and sustainability, every one of those we will do a better job at if we've got the right digital and data underpinnings to allow us to kind of operate more effectively as a system. And that is a really encouraging link to make through. This sets out on the basis of digitise, connect and transform, which mirrors the national policy direction for digitising across health and care. If we think about digitise, that's across our provider organisations who provide the health and care services. At the moment focused on the NHS and on adult social care, but we also need to strengthen the links into the voluntary sector as well, and I'll come back to that in a moment. Connecting is then thinking how we, on a day-to-day basis, make better use of that data, things like shared care records, so that anyone has got access to the right information about a patient or a resident they're engaging with to make the right decisions. And then transforming, and this is really about the data foundations that allow us to do everything from the targeted population health management, thinking about Saqib's observation earlier around household specifics from inequality. The data is out there, we need to make it available to have those decisions and support those interventions. Right the way through to developing new treatments and making our population's data available in a safe and secure way to inform the researching and development of new models of care, new drugs, and improving our overall health outcomes in a way that's much more safe, secure than it is today. Doing all of that requires us to have the right workforce and skills across the system. So that's everything from the digital and data professionals through to the entirety of the health and care workforce who will expect to engage in different ways. And then our general population, who we will continue to be looking at providing a raised set of capabilities to meet the raised set of expectations that they have through how they engage in their everyday life otherwise. But we need to be mindful of doing that in an inclusive way that doesn't exacerbate inequalities any further. And reflecting back to a comment on the JFP, if we approve this strategy today, we've got an accessible version of it available to put onto the website as well, so that it's not just in the graphical version shown here, but also a simpler version that will be available to all. In parallel to this, there's a national piece of work right now to establish a baseline of digital maturity across the country. This was last done in 2017. The strategy itself, we needed to get ahead of the game, so our self-assessments included in here. We're currently going through a peer review process across the system, the region and nationally, which will be published in the summer once the national team have continued the validation. But all the indications from that peer review support what's in here, and there's no expected material deviation or change from the direction as set out. So I really look forward to any discussion around this and support any questions that need to be answered.
Thank you, Ross. Really important. I mean, this is our first sort of key strategy, enabling strategy, and as you say, we are as a system reliant upon the data. You know, we are as good as the data that we have, and how we can focus and perform going forward. So, colleagues, I'm hoping there are some questions and some thoughts for Ross on this digital strategy. Anyone would like to comment, if not just to say anything? Rachel.
Hi, Rachel Corser, Chief Nursing Officer. Just to thank Ross really and his team for the really wide engagement, and I think particularly reflecting the tens of thousands of clinicians and informaticians that we have that sit within that clinical workforce who are really excited by this strategy. And I think, you know, we're in a really unique position to champion this agenda, to really make a difference to how our clinicians feel at work, so that they can spend more time providing direct care to their patients, to their citizens, and having tools at their fingertips that really make a difference. So just a big thank you to Ross and the team, but also I think this is such an important enabling strategy for us as a system, and a really exciting time for us to transform.
Thank you, Rachel. Any other comments? Aidan?
Thanks, Sim. Aidan Rave, Non-Executive Director. Ross, this is a question actually around common infrastructure, if you could possibly elaborate slightly on it, because one of the, I mean, hanging around the public sector for about 20 years now, as I have, one of the most, that sounds a bit sinister, I don't know. Maybe I'll rephrase it. One of the things that's commonly come up as a challenge is data transfer between different organisations and a single view of patient, citizen, service user, whatever you want to categorise somebody as. Where are we on that? Are we moving further towards a position where we've got that ability to move data safely across different organisational boundaries in order to create a much more kind of holistic and coherent service to people?
Should I take that one now? Chair, yeah. So I think it's a great question, and it is a very complex space to try and work in, and trying to make sure the right data is available to people that need to access it. We're probably shifting away from a world of moving data around to a world of where we access data where it is. That helps us move away from it being filtered and changed and potentially becoming unrecognisable and less useful. So there's considerable progress being made across our system and with partner systems, particularly Frimley, to really get models in place that allow us to share data much more transparently and make it available to those who need to access it. But it's non-trivial because we've got to make sure we do that in a way that protects the rights of the people whose data it often is. So the patients often whose data is need to make sure that they understand how we're using the data and the kind of decisions it may well be used to inform. So I would welcome coming back actually in about 6 to 8 months and being able to provide a really strong update on how we're turning this strategy into action, because I think by that point in time you would see a real difference in the quality of the information we're able to access on a day-to-day basis if we can get this really landed and making progress.
Stephen.
Yeah, thank you. So just 2 comments. Firstly, I think it's a brilliant piece of work. Well done, Ross, and for all of the reasons that others have said. The strategy clearly references the importance of partnership in this, and it's great to see some very specific projects linked to adult social care. So fantastic on that. I just wanted to place 2 issues in your consciousness, if they're not already there, for consideration. So one is we do a lot of work as partners around children and the relationship between health and social care around children, and it might be worth us exploring where there are potential in relation to some of the services to children to be even more explicit around how digital might help in that space. And then secondly, it's just referring, I think it was Steve who referenced earlier, the developing assurance methodology for ICSs, but equally so there is a new assurance methodology being introduced this year for adult social care, and the use of data from all of the systems to support that is going to be really, really important. So well done, and it's really great. I would say to us, and I would just reaffirm what I think I'm hearing from us, that we should use this as a real opportunity to push forward our productivity improvements, our quality improvements, our experience improvements, whether it's for staff, citizens, and we should be really bold with this.
Thank you. Shaheen.
I just want to comment. Shaheen, Primary Care. Thank you. I just wanted to comment really that with regards to IT, there's a great variability in primary care across Bob, in hardware and software. But it appears that in the last few months that the IT and digital team have been really quite receptive, and I've been whining quite a lot at my level. And actually, thank you, because that's the only way that we can move together and move forward as practices.
Okay, that's really good. Good to hear.
Ross, thank you. I think it's fantastic and really pleased to hear that you'll be coming back in 6 to 8 months with an update. But this is an area where, again, I think this system should be cooking on proverbial gas, given some of the resources available, whether it be the Big Data Institute. You think about some of the academics at the University of Oxford who are developing virtual reality to treat various psychological conditions. So, I think harnessing the potential that we have within our geography to really sort of give this agenda some proverbial rocket fuel will be key to how we're going to transform the system and hopefully become, the system that's at the top of the league table when it comes to this agenda. So thanks again. Thank you.
Excellent. Matthew.
Just noting the sort of financial dynamic to this. I think it's a terrific piece of work, and there's obviously a lot of work on behind the costing of it. I think there's a couple of things we need to think about going forward. One is around the benefit side of this, because I think that then plays back into conversations we've obviously begun around the long-term resource management across the system. And I think digital plays such an important part of, what that financial and resource plan is going to look like over the coming years. The other aspect to it is that from a costing perspective, the funding is one part of the equation. The tension often materializes around the impact on our I&E. IT assets tend to amortize fairly quickly, even if you can capitalize them. So that's going to create a little bit of tension, I think, in terms of how we manage our break-even position going forward.
Helpful. Ross, do you want to come back on that, please?
Yeah, thank you. And thank you very much for all the comments. It's extremely useful. I also omitted to address a question from the public, so I'll come back to that at the end of this. I think in terms of the social care work with children, I think that would be really important for us to understand much better. And I think it's an area that I would certainly welcome spending more time with colleagues on. So we'll take up that offer of support, Stephen. It's very useful. And I would agree with Shaheen's observation that there really is a strong variability in the IT that we provide across Bob, particularly in Buckinghamshire, where the current set of IT provided to primary care is not as good as it needs to be, and we've got an active plan in place to address that, both structurally for the long term, but also with some more tactical fixes where we can do. So it's good to hear they're having a positive impact, but we need to continue that. I do not like whenever I speak to a GP or you look on social media and you see a complaint about how long a GP has spent waiting for the computer to log on. That is not a good use of the time of our healthcare professionals. So we are investing in addressing those challenges. I also completely recognise Nick's points about things like the Big Data Institute at Oxford University. Fabulous capability. I was there last week again, spending time with the team. We've got such rich academic talent across Bob that is genuinely world leading in lots and lots of these areas. And part of what we need to continue finding time to do is to make that part of the real world of how we invest and how we transform the way we deliver care and bring that learning across not just me, but clinically, nursing, operationally, everything that we do. And then thinking about the financial aspects, I think there are a number of things for us to consider. The national landscape for funding of digital transformation isn't something we should solely depend on. It comes in fits and starts, and there's an element of political priority that changes quite regularly in terms of what it is it's seeking for us to do. So as developing those long-term plans that really bake into that resourcing model, how digital can unlock capabilities that allow us to think about how we can find the investment, underpin that over a 5-year period or longer, I think are going to be key. So making it, like we do with everything else, digital at the fabric, part of the fabric of how we operate, I think can help us unlock the way we need to invest in it. So that's really helpful. I should come back to the question from a member of the public, which was very specifically about the voluntary sector, and I think a reasonable observation that it's only mentioned twice in the strategy. I would really welcome spending time with the VCSE to understand how we navigate that complex world of the numerous organisations involved in supporting the health and care environment. So I would agree it's not something we've been able to do within the first 10 months of the ICB, but we should absolutely look at as we iterate and develop our thinking.
Thank you, Ross. Very good. Thank you for the work. Are colleagues happy to approve, please, this strategy, part of our enabling strategy, very positively? I've got your approval. Thank you, Ross. Right, moving upward and onward, ever upward and onward. We're turning into Catherine now. You're going to talk to us about the partnership governance self-assessment.
Yes, thank you. So Catherine Mountford, the Director of Governance. So again, a few points of introduction to the paper. I am aware it's quite dry as written, but I suppose if we step back, this is fundamentally about how we organise ourselves to best do our job, and that's been coming out so strongly through today's discussion, both as an organisation and with our system partners. It's obviously good practice to review your governance arrangements on a regular basis, and appears very timely now as we're coming up to the end of our first year of existence, but also remembering that most of the design and the setup of how we were proposing to organise ourselves, how we were going to work was done before we existed and before some of us were in place. So there are going to be bits that don't work as well as they could. What the paper is highlighting and this will be something that we would come back to and look at different bits on an annual basis. So this is proposing a couple of areas for the first year which have come up in terms of how we've operated. So first of all, how we operate as a board, and that would think about our membership. Is our committee arrangements right? Have we got our delegations right? Are things clear? And the second area, and again I think it's come out a lot today, is how we work as that wider, particularly NHS system, but with our local authorities in developing things like a joint long-term resource plan, our joint forward plan, our digital and data strategy, because it's meant to be joint between 7 organisations and we haven't agreed in advance. How do you really make that joint? How do you sign it off? How do you not duplicate things? So those are the reasons for those proposing those 2 areas to the board. Other areas that my advice to the board is important, but we're probably too early, is our ability to delegate to neighbourhood, to place, to other organisations, to providers, to provide a collaborative. So I think we need to work a bit more on how that is going currently, and then review those arrangements. So say proposal to focus on 2 areas, a proposed approach outlined with sort of small group work, the board involved, engagement with our partners through a 360, and I will pick up my question from the public here, which it says that we should reviews should enable peer learning by engaging with the experience of partners, including VCSE sector, people and communities. And the questioner then rightly points out that proposed approach in paragraphs 14 and 15 does not specify any engagement with people and communities prior to coming back to the meeting of the board. So I would respond that is absolutely a very good and clear point, and I think as part of the development of the group that will plan the approach and the work, we will need to consider how we engage more widely in a timely and proportionate way, because there is that balance about ultimately it is the decision of this board for its governance arrangements, but we should share our proposals and take input to those before we make that decision. Happy to take any comments or questions from the board.
Thank you, Catherine. As you say, always good practice to reflect on our own performance. And I wonder, Aidan, do you have any comments or thoughts on this? I know that you do quite a lot of work with other boards and good governance, and any thoughts?
Yeah, thanks, Chair. Aidan Rove, Non-Executive Director. I mean, the thought that immediately struck me was that a lot of the work, particularly relating to the public question, which I thought was very fair, but a lot of that work's happening within the committees as well, isn't it, of course? So I think one of the challenges is to ensure that the connective tissue between the committees and the main board is as effective as it needs to be, which is precisely what a governance review should be exploring, and I think will do in this case. I think, you know, in terms of reflecting on wider systems, there's absolutely the point that there's been I think this is picked up in the Hewitt review, by the way, a kind of feeling our way along sense of, you know, how do we make this work as effectively as we possibly can? So I think, you know, most systems will be doing what we're doing, which is reviewing how the first year's gone, how the governance arrangements work. And I suspect there's an opportunity for us to tweak and to improve and to make more effective. So there's the challenge for us, and there's the opportunity too.
Thank you, very helpful. Any other comments? Margaret, please.
Thank you, Chair. I think it was interesting to read your paper, Catherine, in relation to the conversation we're having this afternoon, actually, on the, we're looking at another peer review that's taken place for the system thus far. And a lot of what came out in the LGA peer review, the governance is one little piece of it. So it's not what committees you sit on or what decisions you want to be part of or who's where and what seats allocated to who. It's a much deeper conversation about engagement, interaction, and appropriateness of it and engagement interaction, and using people's valuable time, which isn't necessarily sitting on a committee or sitting on a board. So I guess when this work comes to fruition, what's in my mind is all the questions that this afternoon's conversation is going to open up. It gives me a different lens than what I had when I just read the paper on its own. So I'm hoping that we'll bear those things in mind, rather than we've got 20 places here and we need 18 people and we need 3 counties and 5 places, and the kind of numeric logistical approach to it I don't think is the way to go, which I know you won't be doing. Thank you.
Stephen.
Thank you, and I really liked your paper, Catherine, so well done. I just wanted to raise the question around delegation. We have a number of very different places within the ICS, and they are different in a variety of different ways. And in the context of this, I think there are differences in the history, the level and infrastructure that supports partnership, as well as, I think, ambition to use some of the flexibilities that the ICS gives. I'm anxious that we may default to moving at the slowest pace around assurance when it comes to delegation to place, and I wonder whether there's an opportunity to not necessarily invite place to consider whether they would want to explore some of the flexibilities that might come with delegation. But if a place was keen to take on some delegated responsibilities, that wouldn't be immediately rejected. I do worry that we might end up becoming comfortable with an ICB, an ICS structure that retains more at ICS level than perhaps it might need to, because we wait for that confidence to develop. So it's I suppose a challenge, but in the form of a question.
Rachel.
Thank you, Chair. Rachel Corser, Chief Nursing Officer, and just to add to what Chief Exec's report highlighted this morning around the work that the Care Quality Commission are doing on supporting assessments of systems, particularly around their leadership, their integration and quality and safety oversight. And I think this gives us that opportunity to use the work the independent review will do to form and help with the CQC's form view of us as a system as well. So it will add weight into that as well. And I think for the first time, systems and commissioners are not immune to those inspections and oversights from the regulator. So really welcome that opportunity.
Thank you, Rachel. I'll ask Steve to come back on Stephen Chandler's question/challenge to us. Very, very well put.
Yeah, I think Stephen, simply, it goes back to maybe the comments I made earlier today, that the value of this system and our role within the ICB is founded on 3 strong places, or actually 5 strong geographies when we think about the local authority environment within Berkshire West. So I think, this iteration, I think, Catherine, of our governance review is kind of the first stage at year 1. And I don't think it is then waiting for year 2 to kind of a further review in another year's time to think about delegation. I think, how we actively look at delegation, the role of the ICB within the system at aggregate level, but the ICB being a really good partner within place-based partnerships at local level, and therefore how we can enact more and more delegation where that's right for our strong places to support their strength. I think that should actively be the sort of the work and the mission of the ICB. So I definitely wouldn't see this governance review as a way that is kicking down the road some aspect of getting into delegation. whether it's a place delegation or indeed provider collaborative delegation that we have, where we've got that opportunity of working through provider collaboratives across the system.
Thank you. Any other comments, please, for Catherine to take away? Happy with the approach and the way that we're going to look at this. I'm very grateful actually for those comments, so that'll all be included when we go away and think about this now. Excellent, thank you. So moving on to the Board Assurance Committee reports. Now, I think we'll take them as read, but can I ask our chair colleagues of each subcommittee just to add a little bit of flavour, or is there anything particularly you want to highlight? And if we start with Saqib on audit and risk, is there anything you want to draw to our attention, please?
Thank you, Saqib Ali, Audit Chair. The only thing I wanted to highlight was the comment that we've put under alerts. And also about the length of papers. So I think that perhaps applies in general in every board I've been. So to focus on what we're trying to get out of papers and to reduce the volume by moving things into appendices. But also you can see the update on internal audit and external audit. But I wanted to also thank the finance team that are working, very diligently dealing with 3 CCG accounts as well as an ICB account, and dealing with coming together as a new team and 2 new CFOs over the course of the year that they've been in operation. So that's it. Thank you.
Thank you, that's great. People is me. We've had 3 meetings so far, so we're just starting to scratch the surface. I would say that from a people perspective, there's more work to be done to get our grip and control. But what we've done and started to do is separate a system perspective on people and then an ICB specific section, realizing that we do have 300 to 400 staff that report in to us. So we're coming to terms with that. Would you say, Karen? More work to be done, but progress is good so far. And we're just making sure from a system point of view that we have the right members in our midst and the right attendees. Place and system development. Aidan.
Thank you, Chair. Right on cue, my battery's just died. But that doesn't matter because there's not a huge amount to elaborate on the report, so we can pretty much take it as read. We've covered most of it today anyway. Just to say that the academic health network discussion was very helpful, and we're keen to revisit that in the near future too.
Excellent. And we've heard today the importance of place, I think, very firmly in our midst. So if I move to Margaret, who chairs the Population Health and Patient Experience Committee.
Thank you, Chair. Nothing of substance to add, just to point to the unexpected conversation we had after we were meeting just after the flood at Reading Hospital. And the conversation went on to the impact of infrastructure, failing infrastructure across our trusts, and what impact that might have on quality, patient harm, patient care and so on. So led to a request for further information. And the other observation actually on inequalities was and it's come through the conversation today about the link with place, and how what we're looking at across the system and what's happening at place, the interaction between the 2 committees, Aidan, I think is really critical for us to think about. Thank you.
Excellent, thank you. And then Tim, please.
Thanks, Sim. The first 2 elements in red have been touched on in detail now during today's meeting and slightly updated, so I won't go into those. Just skipping to the green part briefly, which is assurance, just to echo the point Shaheen made earlier, that we get a regular report on digital performance, and it very much echoed Shaheen's experience, was that out in the field where the rubber hits the road, the team under Ross's guidance are doing a great job. I think we're hitting all the SLAs. Of course, we could always do things better, but the performance is very strong, so that was very positive. I'd just like to spend a moment or 2 talking about the orange parts, which the 2 important things there. One was capital. We've only really got into the detail on the capital side of the system in the last 2 to 3 months, really, and we're still not quite there. But we had a good presentation from Nikki, who's the CFO over in Berkshire, which was very helpful. But also, the summary is there's work to do, and it goes back to Margaret's point a moment ago about estates actually and infrastructure. So there's a lot of work to be done on that. So it's a sort of keep in view item. And then the final point is right at the bottom of the first page into the start of the second, which comes back to Stephen's question of probably about an hour or so ago about efficiency programme. And Matthew mentioned that there's a group being put in place, which is this IECG, And this was an initiative of Jim's originally, when looking at why did we not deliver the 22 million system figure last year, system improvement. Jim, with the CEOs and CFOs, identified that the key issue was resource and focus. It wasn't that we didn't want to do it and we didn't know how to do or where to do it. It was the focus and putting the framework and process behind it. So Jim, working with a guy called Jamie Drake, has come up with this system. And as Matthew said, they've got a large selection of projects that could help us. And they've narrowed it down to 8 at the moment, and there's a lot of work going on. And the final thing to say about this is it's a really good example of system working, because we've got Jason, who's the CFO in OUH, is leading that with Matthew's help, of course. And I think it's really going to be, it's not going to be the ICB imposing our thoughts. It's going to very much be ideas coming from the system and the partners in the system, and then sharing that best practice wherever we can. But with ICB giving the support in terms of a bit of resource and some project management skills. So it's a really good example, I think, of us working how we should be. The ideas coming from the ground up, but we're sort of helping put our arms around it and guide it a bit. So I'm really hopeful that will be a big asset going forward. And I also think it's going to be very important, because I suspect NHSE are going to expect to see some tangible output from that group. So I think you'll find that on the report week in, week out, or month in, month out, I suspect, going forward. That's it.
Thank you. Thank you for that detail, Tim. And I hope that gives the board assurance that the subcommittees are present, working, and will continue to really dig in and focus on some of the key issues and a bit of the detail. So moving forward, Catherine's just going to talk us through the forward plan.
So as always, we have for information the forward plan for these are meetings in public, so you can see what's coming up. July is probably fairly settled and quite full, and then I've taken a note that we were going to bring the digital data and strategy back into action back in 6 to 8 months, and there was also the comment on the kind of primary care access reports implementation, so they will go on to the forward plan and again identify items to myself or Aman, so we can keep this up to date.
Excellent. Any thoughts or questions on that? No? Well, then it just leaves me to thank all colleagues here in this room. And a continuous thank you to everyone that works in our system, both at the ICB, within the partner trusts, within our local authorities, primary care. We can't do this alone. And the more we bring our partners into play and the more we concentrate on place, the more we'll be able to deliver. So I think this has been a really good discussion today, and I'd just like to thank all colleagues. If there's no other business, I'll formally close the meeting and thank you and look forward to seeing you all in July. Thank you.